Good morning, ladies and gentlemen. As today is the last day of our work, we will do our best to complete the task assigned to us. You have been efficient so far. I thank you. So in order to smoothen our business for the day, I propose we take the items in the following order. 1. Approve our third report. 2. Item 15.3 Mycetoma will become the first agenda item of item 15. 3. Item 15.1 Draft Global Health Sector Strategies. 4. Item 15.2 Global Vaccine Action Plan. And 5. Item 16.1 Health Workforce and Services. 6. Item 16.2 Follow up to the report of the CWG. 7. Item 16.4 Addressing Global Strategies of Medicines. And 8. Item Progress Report. So this is the order that we would like to propose for our work for today. Is there any observation or intervention or rejection on this our proposal? If there's no any objection, we will go on with our work for today as the following order. This one. And there is, before we start our work, there is an announcement from the Secretariat that the travel agent is available at door 40 until 13 at 13 for ticket change. So if you have any demand to change the ticket, you have to go to the travel agents before 1 p.m. Today. Thank you. So we now will take up agenda item 15 on communicable disease, sub item 15.3, right? 15.3. We will now consider sub-item 15.3 on Mycetoma.
No, 30.
Okay, sorry.
30, that's one.
Okay,
15, that's correct.
that's correct. The relevant document is A69/35. Under this item, we will consider the draft resolution EB 138.R1 contained in EB 138/2016/record/1. I first give the floor to our Executive Board Chair, Dr. Precious Masoso from South Africa, to make some introductory remarks. Dr. Masoso, you have the floor.
In January 2016, the Executive Board, at its 138th session, considered a report by the Secretariat describing mycetoma and a draft resolution. This was in response to a request by member states at the 68th World Health Assembly. Approximately 17 member states took the floor, and many member states expressed appreciation for the work of the Secretariat and supported the draft resolution. Some member states expressed concerns about the absence of a systematic, technically driven process for the evaluation and potential inclusion of additional diseases among the neglected tropical diseases. This led to substantial discussions with an amendment of the draft resolution to include a request to WHO through the Strategic and Technical Advisory Group for Neglected Tropical Diseases, NTD STEC, to define such process. With this amendment, the Executive Board decided to endorse the report of the Secretariat and the resolution contained in document EB 138/R1. The board further decided to forward the report and the resolution to the 69th World Health Assembly for adoption. The NTD STEC has met on the 12th to 13th April 2016 and finalized this proposal that is available on the WHO NTD website. The World Health Assembly is therefore invited to consider the draft resolution contained in document EB 138/R1. I thank you.
Thank you, Dr. Masoso. Now the floor is open for discussion. I give the floor to the delegate of Niger.
Merci.
Thank you, Chairman. Chairman, Niger has the honor of speaking on behalf of the 47 member states of the WHO's African region in order to address agenda item 15.3 on Mycetoma. I would first of all like to thank the Secretariat for the quality of the documents which have been submitted for our consideration. Chairman, during the 68th World Health Assembly, various delegations mobilized in order to try and ensure that mycetoma, a very seriously handicapping disease, would be put onto the list of neglected tropical diseases as a matter of urgency. It is a chronic inflammatory and destructive disease which affects the skin, tissue and bones, and it has various serious negative economic and social consequences for people, for the community, and for the health structures in the regions affected. It is endemic in Mexico, in Africa, and in other areas 15 degrees south of the equator to 30 degrees north. In Africa, it spreads through Mauritania, Senegal, Somalia, the north of Kenya, among other regions. As I say, it's a tropical infection, it's related to poverty, and it has been neglected. The worldwide burden of mycetoma cannot be assessed accurately because we do not have the necessary detailed data on the incidence and prevalence of it or of the damage it causes. However, having said that, the UNICEF, World Bank, UNDP, and WHO Special Program of Research into and Training on concerning neglected tropical diseases has, through the regional offices, offered opportunities for bringing about an improvement in surveillance of and control of mycetoma. The initiative on drugs against neglected diseases has also tested a new promising treatment for mycetoma as part of its 2015 to 2023 action program. Since 1991, a National Center of Research into Mycetoma has existed in Khartoum, and the African region gives strong support to any action that might lead to assistance being given to that center and the WHO laboratory so that we can increase knowledge of the disease and improve the strategies that we have to fight against it. In order to strengthen our fight, we have submitted a draft resolution to the Assembly last year by Sudan, and we have one this year which invites those states where mycetoma is already a burden or a risk to begin tackling it. In conclusion, the African region would like to support the implementation of this resolution and urges member states and the Secretariat to work in order to bring that to fruition. Thank you.
Thank you, Sudan. Thank you, Nature. Sorry. I give the floor to Sudan to be followed by Saudi Arabia.
Good morning, Mr. Chair. Sudan would like to express its sincere thanks and gratitude for the Secretariat for preparing this document about mycetoma, as well as to the EP member states for seeing and discussing this technical report, and for the STAC committee for seeing and producing this system for including drug diseases in the list. Mycetoma, Mr. Chair, is one of the badly neglected tropical diseases affecting the poor of the poor in poor remote communities. The patients are of low socioeconomic status. They are having many stigma and they have a lot of problems. On behalf of Sudan, I would like to request the Assembly to endorse this document so as to improve the quality of life of patients with mycetoma, to improve and to narrow the gap in knowledge in mycetoma so as to have a very clear pathway for the management and care of this patient. Thank you very much, Mr. Chair.
Thank you, Sudan. Now give the floor to Saudi Arabia to be followed by Kenya.
شكرا سيد الرئيس.
Thank you, Mr. Chairman. Mycetoma is a heavy health and economic burden for many societies. Most of them are communities which receive a less share of health care. It is a devastating disease at all levels. Lack of diagnostics or means to care for the disease or its chronic complications. Research and development never gave this disease its due attention due to lack of finances or due to the stigma associated with this disease. The addition of this disease to the list of orphan disease will undoubtedly help to, in fact, harness finances and attention. Mr. Chairman, we support the draft resolution sponsored by Sudan, and which calls on this Assembly to approve the draft resolution based on document EB 138R1. Thank you.
Thank you, Saudi Arabia. Now give the floor to Kenya to be followed by Iraq.
Kenya aligns itself to the statement made on behalf of the African region on mycetoma that has just been delivered by the Republic of Niger. Mr. Chairperson, mycetoma is currently not considered endemic in Kenya. This position, however, is not based on scientifically informed mapping protocols. In fact, there have been unofficial reports of suspected mycetoma-like cases in some parts of the country. Mr. Chairperson, though mycetoma is not monitored under our national surveillance system, we are alive to the fact that the country remains at risk of this disease. This risk is informed by several factors, including the following. 1, a significant part of the country lies within the mycetoma belt, which stretches between the latitudes of 15 south and 13 north of the equator. The conditions that favor the disease, that's number 2, such as short rains and prolonged dry seasons and presence of thorny bushes, exist in the arid and semi-arid areas of the country. 3, Kenya borders Sudan, where 2,555 reported cases have been documented in a systematic review and meta-analysis carried out in 2013. Mr. Chairperson, Kenya recognizes the need for this condition to be included in the neglected tropical diseases priority list, as it is only through this inclusion that the disease will attract donors, funders, and pharmaceutical bodies' awareness and attention, which will subsequently lead to more research, informed health education, and advocacy programs that will eventually lead to better medicines, diagnostic tests, as well as better and effective prevention and control programs. Mr. Chairperson, it is for the above reasons that Kenya aligns itself and supports resolution EB 138.R1 2006, which was adopted by the Executive Board during its 138th sitting and further urges the Health Assembly to adopt it. I thank you, Mr. Chairperson.
Thank you, Kenya. Now we give the floor to Iraq, to be followed by Republic of Korea.
Mr. Chairman, on behalf of the countries of the Eastern Mediterranean region, I would like to thank the Secretariat for its technical report on mycetoma, and the Executive Board and the member states for addressing one of the most neglected diseases in the world. Mycetoma has serious and horrible outcomes for affected population, most of whom are poor and at their most productive age. The chronicity of the disease means that it often passes unnoticed in the early stages and then presents with many complications leading to loss of one or more limbs in numerous patients. It may also present in the head or the neck. The mycetoma belt covers many countries across 4 WHO regions, and due to its slow progress, may also be silent disease in other countries outside the mycetoma belt. The number of people currently diagnosed with mycetoma is thought to be just the tip of the iceberg. Its diagnosis is a burden on patients and health systems alike. Patients undergo many rounds of surgery and may be hospitalized for long periods with complications depending on the severity and chronicity of the presentation. Available medicines are high cost of variable efficacy and create an additional economic burden on patients and their families. There is considerable knowledge gap concerning this disease. Preventing the disease needs research in the affected and the suspected communities. More data and information are required on the epidemiology and global burden. The treatment regimen, especially for the fungal mycetoma, needs to be improved. In short, there is much work to be done on the debilitating and neglected disease. Including mycetoma in the list of the neglected tropical diseases will encourage partners and the global health community to move forward in developing better diagnosis tools and medicines, which in turn will help ensure affected communities are not left behind as we strive to achieve the new Sustainable Development Goals. Member states of the IMRO region support the resolution proposed by the Executive Board, EPI 138/R1, and urge the Health Assembly to adopt it. Thank you very much, Mr. Chairperson.
Thank you, Iraq. Now we give the floor to Republic of Korea, to be followed by Japan.
Thank you, Chair. The Republic of Korea appreciates the WHO Secretariat's effort to prevent and control neglected tropical diseases, including mycetoma. We recognize that some diseases closely linked to poverty in tropical regions, including mycetoma, are still being neglected. The Republic of Korea fully supports WHO's effort to improve its surveillance and management system for prevention and control of mycetoma. Thank you very much.
Thank you, Republic of Korea. Now we give the floor to Japan, to be followed by Thailand.
Thank you, Mr. Chair, for giving us floor. Neglected tropical diseases are clearly mentioned in SDG targets. Japan welcomes the Secretary report, and also we support the draft resolution. Our concern at the EB was fully explained by the Honorable Chair of the Board this morning. Needless to say, NTDs in WHO are 17 diseases which we have agreed focused actions. We felt clear procedures is needed when modifying the list of 17. Therefore, we attach great importance on operative paragraph 3.6 of the draft resolution, which urges clear process for assessment. Finally, Japan welcomes a new NTD family member, Mycetoma, and already one of our pharma company is studying its medicine. Thank you very much, sir.
Thank you, Japan. Now I give the floor to Thailand to be followed by USA.
Thank you, Chair. Thailand would like to express sincere appreciation for the great efforts made by WHO, UNICEF, UNDP, World Bank, and development partners in tackling mycetoma, in particular a number of key activities at the WHO Collaborating Center on Mycetoma in Khartoum. Furthermore, there are remaining challenges including lack of basic epidemiological information, delayed detection, and poor treatment outcome. Chairperson, mycetoma has always been neglected as it was prevalent in some countries among mycetoma belt, where the resource is constrained, and it is a chronic condition which is not dreadful like Ebola. Thailand supports the draft resolution EB 138 Arc 1. We would like to emphasize that inclusion of mycetoma in the WHO neglected tropical disease is a stepping stone to accelerate the implementation of mycetoma prevention and control, including health education, personal hygiene, and environmental sanitation in affected countries. We would like to sincerely thank and commend Sudan for their leading role in moving this resolution. Thank you, Chair.
Thank you, Thailand. Now I give the floor to USA to be followed by South Africa.
Thank you, Chair. The United States supports the resolution as drafted. We also associate ourselves with Japan's drawing attention to the paragraph 3.6 about the WHO setting up criteria and process for in the future deciding on criteria for neglected tropical diseases. And we also draw attention to the resolution's emphasis on effective prevention strategies because we know very little about mycetoma and there's a need for rapid diagnostics and better drug treatments. Thank you very much.
Thank you, USA. Now I give the floor to South Africa.
Chairperson, South Africa supports the statement read by Nigel on behalf of the Africa region. South Africa acknowledges the fact that mycetoma is one of the neglected tropical diseases of public health concern. Therefore, South Africa supports the recommendation from the WHO Secretariat. The recommended actions, such as advocacy for improved surveillance and control, will help countries to determine the status in terms of prevalence and the at-risk groups. Therefore, facilitation of the advocacy in support of awareness, stimulation of the generation of further knowledge, and encouragement of the development of appropriate control tools and strategies for inclusion in the WHO portfolio of NTDs, as well as the UNICEF, NDP, World Bank, WHO Special Program for Research and Training in Tropical Diseases are supported. There is a need to guide countries in conducting situational analysis and develop sustainable surveillance strategies. In conclusion, South Africa supports in principle the recommendations as outlined in A69/35. I thank you.
Thank you, South Africa. Now I give the floor to Switzerland.
Merci, Monsieur le Président.
Thank you, Chair. Switzerland supports and warmly welcomes the implementation of a technical system to identify members of this disease family. Switzerland has the advantage of supporting this resolution. Thank you very much.
Thank you, Switzerland. I do not have any further speakers on my list. So I shall now ask the Secretariat to respond. Dr. Ren Minh Cui, you have the floor.
Thank you, Mr. Chair. Distinguished delegates, I thank you for your constructive reflection and comments. The discussion that has taken place on the mycetoma during a recent WHO governing body meeting illustrates the fact that there are still a number of tropical poverty-related diseases or conditions that remain neglected politically, socially, financially, and technically. Mycetoma is one of such diseases for which current prevention and control strategies are not of nature to make a substantial impact. With the adoption of this resolution, the WHO Secretariat will and collaborate with partners for improved surveillance and control of mycetoma, and for the development of tools and strategy that will enable health services to appropriately manage cases of mycetoma. The discussion on mycetoma has also triggered the definition of a systematic technical-driven process to evaluate and potentially include additional disease among the neglected tropical diseases. In this regard, I would like to thank the strategy and technical advice group for neglected tropical diseases for its contribution to develop the process. Now the details of that process are available on the WHO NTD website. WHO Secretariat will tailor its mandate to the needs of that persist for poverty and leave nobody behind. With that, I thank you very much for the chair.
Thank you, Dr. Ren Mingkui. We will now consider draft resolution EB 138R1. Is the committee ready to approve this resolution? I see no objections. So no amendments have been proposed to this resolution. I therefore take it that the committee is prepared to approve this resolution. So the resolution is approved. That concludes our consideration of sub-item 15.3. So we now take up agenda item 15.1, sub-item 15.1, draft global health strategies. The relevant document are A69/31, A69/32, A69/33, A69/59, and A69/59 addendum 1. China, you have the floor.
Distinguished Mr. Chairman, China would like to thank the Secretariat for the 3 draft strategies and supports the priority areas and prevention and control measures included. We attached great importance to prevention and control of those diseases. We have integrated the HIV-related SDG into our future 5-year plan. The severe prevalence of viral hepatitis has been contained. In 2014, the prevalence of HBsA among the population aged 1 to 4 was 0.32%. Furthermore, through the National Negotiation Mechanism of Drug Prices, the price of common drugs against chronic hepatitis B has dropped by 67%. China pays great attention to 3 draft strategies and would like to suggest the following. First, discrepancies exist among member states.
Can we open the floor for discussion first? Then we will start with your intervention again. Sorry about that, China. So I think that we will start the discussion on sub-item 15.1 on HIV's 2016-2021. The relevant document is A69/41 report by the Secretariat. So the floor is open for discussion. So I give the floor to China. Okay. Again, you can repeat again. Sorry.
Thank you, distinguished Mr. Chairman. I just read briefly the position of China for the 3 drafts. We support those 3 drafts, and we also explained the progress on fight against the main diseases. Now I would like to present our 3 suggestions for the draft strategies. First, the discrepancies exist among the member states. We should respect those differences and allow for adjustment of part of the indicators and the domestic prioritized action. Second, HIV and STI are not only public health issues, but also a complicated social problem which require multi-sectoral and multidisciplinary efforts. We hope that WHO will further enhance its coordinating role, stressing on multi-sectoral cooperation and participation of the entire society. Third, WHO should further increase financial and technical support to developing countries, give full role of its international clout in coordinating relevant pharmaceutical companies in their endeavor of lowering the prices of medicines, including the prices of antiviral drugs. Thank you, Mr. Chairman.
Thank you, China. Now I give the floor to Australia to be followed by Iraq.
Thank you, Chair. Australia thanks the Secretariat for its report and commends the WHO's efforts to assist member states to respond to HIV, viral hepatitis and sexually transmitted infections. Australia endorses the 3 draft strategies and is pleased to co-sponsor the draft resolution, acknowledging that while there have been many successes to date, progress remains uneven and inequitable. We especially welcome the first global health sector strategy on viral hepatitis, which provides recognition of the significant burden posed by the disease. We note the speed and scale of the response required to end the HIV epidemic as a public health threat by 2030. Australia acknowledges the amendments made by the Secretariat and would like to recommend that the common activities across the strategies are highlighted to assist member states to prioritise actions and leverage combination interventions that will have broad benefits in reducing HIV, viral hepatitis and STI rates, particularly in resource-constrained environments, and that reporting requirements are streamlined to reduce the reporting burden for member states. We welcome the use of universal health coverage as an organising framework for the 3 strategies to help facilitate greater coordination of activities to address these major health threats and ensure that national responses are cost-effective and sustainable. Australia recognises the significant challenge of affordable access to effective new treatments and encourages the WHO to continue to assist member states in price negotiations. We applaud the efforts of the Western Pacific Regional Office in supporting collective negotiations to increase affordable access to hepatitis C medicines. Thank you, Mr. President.
Thank you, Australia. Now I give the floor to Iraq to be followed by Cape Verde.
Thank you, Mr. Chairman. I am speaking on behalf of the member state of the EMRO. I welcome the 3 global health sector strategies, including their ambitious goals of the ending AIDS and STD and eliminating viral hepatitis as public health threats by 2030. The HIV epidemic is still growing in our region. Deaths due to the AIDS are increasing, while access to antiretroviral therapy has steadily improved. The overall regional coverage with ART remains below 15%, the lowest in the world. Achieving the ambitious global HIV diagnosis and treatment target will require major investment and new approaches to service delivery and financing. The death toll due to the viral hepatitis in our region is almost 4 times that of HIV. High rates of the new infections with hepatitis C are maintained primarily due to unsafe practices. Recently, we witnessed rapid scale-up of hepatitis C treatment in Egypt following successful negotiation with the pharmaceutical companies to reduce the price of medicines by more than 90%. However, the cost of hepatitis treatment with a new generation of medicines is still prohibitively high in many countries. We need affordable diagnosis and medicines to achieve the global goal of eliminating hepatitis as public health threat. We note with the satisfaction the experience of 4 countries in our region who are now producing generic hepatitis medicines with very low prices: Egypt, Morocco, Pakistan, and Tunisia. These challenges prevail at a time when our region is experiencing an unprecedented number of the people affected by the humanitarian crisis. This has drawn the attention to emergency relief efforts and has slowed the national responses. New groups of displaced people have emerged that have limited access to HIV, hepatitis, and STI prevention, diagnosis, and treatment services. We are keen to eliminate HIV, STIs, and viral hepatitis as public health threats in our region, and we count on WHO to support us in our efforts to adapt our policy and service delivery models to scale up access to prevention, diagnosis, care, and treatment, and subsequently in our endeavors to mobilize the necessary investment for that purpose. We endorse the threat global health sector strategies for adoption. Thank you very much, Mr. Chairman.
Thank you, Iraq. Now I give the floor to Cape Verde to be followed by Switzerland.
Merci, Monsieur le Président.
Thank you, Chair. Cape Verde is honoured to take the floor on behalf of the 47 member states of the African region on item 15.1 and thanks the Secretariat for submitting this draft global health strategies against viral hepatitis 2016-21. This is a international public health problem comparable with other communicable diseases such as HIV, tuberculosis or malaria. The burden it has on population in regions across the world, hepatitis is not often considered as a health priority until recently anyway. This is a positive change with the adoption of the resolution on sustainable development for 2030 and goal number 3 calls for measures to combat viral hepatitis. This global strategy describes the path to follow and the general objectives for eradicating viral hepatitis, which is a great threat to public health, and to do so by 2030. Document should also indicate clearly that the current cost of preventative and treatments, particularly vaccinations and medications, are exorbitant and prohibitive for health budgets for the majority of developing countries. The draft strategy offers a framework for a concerted intervention on behalf of the Secretariat and Member States on a global, regional and country level, and it is based on good current practice and available data as regards the efficiency of approaches and interventions in the health sector as regards hepatitis. Thus, Member States in the African region supports this global health strategy against viral hepatitis 2016-21 and also its framework of application that is proposed. Member States would call on all member states of the WHO not only to participate in the mobilization of all necessary resource for this, for prevention and control of viral hepatitis, but also to protect and promote the rights of people, gender equality and equitable access to health. Our member states would invite the Secretariat to work with the pharmaceutical industry and partners to reduce the cost of medication used to treat hepatitis. We continue also to advocate for the implementation of a new tools and also improving existing tools in terms of controlling viral hepatitis. Thank you very much.
Thank you, Cape Verde. Now I give the floor to Switzerland to be followed by Argentina.
Merci beaucoup, Monsieur.
Thank you very much, Chair. Chair, we welcome the role that these 3 strategies strategies will play, not only to achieve target 3.3 of the Sustainable Development Agenda, but also for implementing the development agenda as a whole. We hope that it will be implemented within the framework of a not vertical but an integrated approach, so that HIV/AIDS can be better managed in primary health care and included in a universal health coverage concept in the spirit of Agenda 2030. We particularly welcome aligning the HIV strategy from WHO with the 2016-21 strategy from UNAIDS that was recently adopted. This coherent, consistent approach will allow us to have a universal commitment to put an end to AIDS by 2030. To date, no country has been able to put an end to this epidemic. We have a priority and a shared responsibility, and we should together put an end to AIDS. We welcome particularly the consultative process that led to the drawing up of this strategy, including across all WHO regions. This is an essential approach to ensure that the strategy can meet the different forms of the different epidemics of the same epidemics across the world. So we recognise that these three documents are technically solid and allow us all to make considerable progress while allowing every country to adapt its response to the particularities of these illnesses. So we welcome the resolution today and will be very pleased to see it adopted. Thank you very much.
Thank you, Switzerland. Now I give the floor to Argentina, to be followed by Austria.
Thank you very much, Chairman. I'm making this statement on behalf of the member states of the Americas region. GRUA would like to take this opportunity to contribute to the debate on the worldwide strategies of the health sector, particularly in respect of HIV, but without leaving aside the matters of viral hepatitis and sexually transmitted infections for 2016-2021. For our region, this disease continues to be a serious concern, although we have brought in new legislation to deal with it and adopted cross-cutting policies to tackle it in our health systems. We applaud the inclusion of the priorities, goals and targets of the UNAIDS multi-sectoral approach and the goals related to health, which can be found on the 2030 Development Agenda. Regional consultations have been an important way of making headway with the vision behind the HIV strategy, but its full application will mean intense work on coordination still to be done at all levels of the organization with member states, globally and regionally, if we are to avoid backsliding in some cases and manage to reach zero HIV in others. Of course, there are differences between regions, and that means that the plan, when it comes to the implementation stage, will have to be both a positive and a flexible tool. We believe that it is, and for that reason we support the adoption of the strategies which we are discussing. We hope that the high-level meeting on HIV/AIDS will be an excellent opportunity for building upon our global commitment to achieve the goals and implement the policies we need if we are to bring an end to AIDS by 2030. We also firmly believe that increased investment in tackling HIV and other sexually transmitted infections will enable men, women, and children to enjoy full sexual and reproductive health, better sexual and reproductive health throughout their lifespan. If we can achieve that, we will make a great contribution to achieving Goal 3 of the Sustainable Development Agenda, and indeed some of the other goals as well. Last but not least, GRUA would like to put on record the fact that sexually transmitted infections continue to be a threat to public health, and we would like to see WHO remain alert to them and act quickly to take action that would be of particular benefit for the most vulnerable groups in the population who are most at risk, which means people living in extreme poverty, people with HIV, young people, and people who have sexual relations with people of the same sex, and of course, last but not least again, drug users. Thank you.
Thank you, Argentina. Now I give the floor to UK, to be followed by Republic of Korea.
Thank you, Chair. The UK would like to thank the WHO for its work on these three strategies. We support their adoption. On HIV, we welcome the clear focus on comprehensive prevention, integration and health systems strengthening. Given the social drivers of infection, the UK agrees that a multi-sectoral approach will be critical to deliver the ambitious goals in this and the UN AIDS strategies. Also critical is the focus on country investment that prioritises cost-effective interventions for those most in need. We urge WHO to support governments to scale up equitably, ensuring the sickest and most vulnerable are not left behind. Similarly, we welcome advances in pre-exposure prophylaxis, but would like to understand how WHO will support governments to consider its safe and effective use. Given the SDG targets combat hepatitis, we welcome the much-needed guidance and advice that WHO will provide to countries. Recent UK guidance aims to ensure those at increased risk are offered testing to reduce the levels of undiagnosed infection. Aiming for hepatitis elimination by 2030 is very ambitious, and we fear that many countries will struggle to meet the strategy's targets. Treatment costs are reducing but remain unaffordable for many countries. Integration of hepatitis prevention and treatment within the broader health system will be essential. We welcome the STI strategy's focus on evidence-based interventions, links to other risk-taking behaviours and the need to address stigma. We strongly support the 2020 milestones to establish national systems to monitor antimicrobial resistance. Thank you, Chair.
Thank you, UK. Now I give the floor to Republic of Korea, to be followed by Austria.
Thank you, Chair. The Republic of Korea appreciates the WHO Secretariat's continuous attention, support, and response for communicable disease. We believe that this is time for close review and global agreement on the agendas for the global health sector strategies on HIV 2016 to 2021. Reflecting WHO's role and UNAIDS multi-sectoral strategy, we need to expand international financial support and strengthen global partnership to achieve the sustainable development goals related to HIV/AIDS. And Korea will support and participate in this effort to respond to HIV/AIDS. Through successful immunization campaign, Korea has made significant progress in hepatitis B prevention and control. We offer HPV screening tests for all pregnant women and fully fund birth dose vaccination and successfully reduced the prevalence of hepatitis B in children less than the age of 5. Korea recently experienced the outbreak of healthcare-associated HCV infection, and we believe that the importance of following the standard precaution and safe injection should be more stressed. In June 2016, the human papillomavirus vaccine will be introduced to the National Vaccination Project, targeting 20-year-old girls, and will be provided for free. Moreover, we wish to raise awareness through adolescent education about safe sex life, with concurrent advertisement promoting vaccination of HPV under cooperation with the Ministry of Education. We'll also cooperate with other ministries for prevention of sexually transmitted infections for adolescents, and will develop and distribute educational materials. It is very important to induce voluntary participation from risk groups for medical checkup and treatment for the prevention of STI and HIV/AIDS. The Republic of Korea supports WHO's global health sector strategy on HIV/AIDS, hepatitis, and STIs, and will actively join this effort. Thank you very much.
Thank you very much, Republic of Korea. Before I give the floor to Austria, I would like to remind everyone that we will consider the report for each agenda sub-item starting from the draft global health sector strategy on HIV 2016 to 2021 first, and then we will consider the latter of the global strategies. So I noticed that some member states also already made your interventions to these 3 strategies. So that's fine for us. But we will consider in order for these 3 strategies, because there's a lot of detail of these 3 strategies, and member states would like to make your intervention on this strategy by sub-strategy. So this is first of the for your consideration. So now we give the floor to Austria, to be followed by Japan.
Thank you, Chair. Austria welcomes the global health sector strategy concerning sexually transmitted infections and the resolution contained in document A6933 and A6959. One of the 2020 milestones of the strategy is to achieve that 70% of the countries deliver human papillomavirus HPV vaccines through national immunization programs. Austria has started very early to focus on HPV vaccinations to eliminate pre-cervical cancer lesions through the high coverage of HPV vaccines. Not only for girls, but also for boys aged between 9 to 11 years old, free HPV-4 vaccination has been introduced into the national immunization program. While in Austria, herd immunity will soon be reached, our strategy has been proven to be highly cost-effective. Thank you.
Thank you, Austria. Now I give the floor to Japan, to be followed by Thailand.
Thank you, Mr. Chair. And also thank you for your guidance to discuss some strategy by one. But for the sake of the time, I would like to discuss 3 at the same time, and I do not come back again for this under this item. Japan welcome 3 strategies in front of us. They are the first disease control strategies in SDG era. We recognize with satisfaction that they reflect very well a current trend of global health, from a silo approach to a wider one, focusing on the integrated national health services through universal health coverage and stressing its sustainability. Now, I have 3 specific points. First, these strategies do include interventions which may involve local sensitivity. We feel one-fit-all approach do not work. We need certain flexibility in implementation to best results. The paragraph 46, 47 of the HIV strategy very well illustrates this sentiment. In addition, the draft resolution A69/59 operative paragraph 2 regarding member states as well. They are welcome. Second, we concerned about emergence of drug resistance in HIV, STI, and soon hepatitis. Through discussion of AML, we know what to do, but little has been done. We propose to expand drug resistance activities in viral diseases as well, taking advantage of recent development of AML, avoiding duplication, rather making sure synergy with growing relevant activities. Lastly, I wish to stress the unique role of WHO. Many member states have graduated or are graduating from ODA recipient group. Therefore, technical assistance is needed more than ever to transform donor financing to domestic financing of programs, particularly for key populations. I expect WHO to offer maximum support to member states in collaboration with other partner agencies such as UNAIDS and Global Fund. In conclusion, Japan supports the integrated draft resolution A69/59 and commends secretariats to come up with an united, a very straightforward and simple text which is very friendly with environment by saving trees for paper. I thank you.
Thank you, Japan. Now I give the floor to Thailand, to be followed by Russian Federation.
Thank you, Chair. We sorry, Thailand would like to deliver intervention for all diseases, HIV, viral hepatitis, and STI. And we would like to deliver after Timor-Leste, who is the representative of the SEA country, please.
Thank you, Thailand. So now I give the floor to Russian Federation, to be followed by Tunisia.
Thank you, Chairman. We're also going to speak on all three strategies in order to save time. Chairman, the Russian Federation is grateful to the WHO Secretariat for having prepared the reports and draft global strategies on a very important communicable diseases. The strategy is very timely and very important, not only for countries with a very heavy burden of such infections, but for the whole of the international community. We would like to note with gratitude that the comments and proposals which were made by Russian experts at the session, the 138th session of the WHO Executive Board in January 2006, about taking into account national circumstances, domestic circumstances, legislation and legal responsibilities have been taken into account and reflected in the draft resolution on the global strategy for the health sector. We would, however, at the same time like to make it clear that the strategy does not sufficiently reflect the importance of people taking responsibility for their own health or family values and warnings about highly risky forms of behavior. This message is supposed to be to prevent disease and warn about the risks in certain forms of behavior and be directed inter alia at young people so as to prevent the spread of disease among that particular population group. It is extremely important that we remember the content of the third goal of the Sustainable Development Agenda, that is helping all countries, particularly developing countries, to increase their potential in respect of early warning and bringing down both national and worldwide risks to health. The government of the Russian Federation has a state strategy on stopping the spread of HIV in the Russian Federation, and that has taken into account the basic international approaches to and recommendations on controlling HIV infection. We understand the importance of adopting the global strategy for the health sector dealing with HIV, viral hepatitis, and sexually transmitted infections, and therefore, generally speaking, the Russian Federation supports these documents. Thank you.
Thank you, Russian Federation. Now I give the floor to Tunisia, to be followed by Timor-Leste.
Chairman, thank you. Tunisia would like to support the statement made by Iraq on behalf of the Eastern Mediterranean region. Tunisia supports and agrees with the strategy on controlling HIV, sexually transmissible diseases and hepatitis, and would like to congratulate the organization on launching a program to deal with what is a worldwide scourge. Tunisia has strongly committed itself to fighting hepatitis. We have strengthened our national program to control viral hepatitis by setting up a digital and secure registry which ensures the confidentiality of individual medical data. We have also launched a program to eliminate viral hepatitis C using the data we had from the first national viral hepatitis A, B, and C prevalence survey carried out in 2014-2015. The results have helped us to draw up priorities for a plan for elimination based on treatment of all patients, but also on screening and awareness building. Our country has agreed a treatment plan and is now adopting a strategy to bring down the cost of antivirals so as to ensure universal access to treatment. We welcome WHO's initiative and urge it to give Tunisia support as it implements its own program, particularly on screening and follow-up treatment of patients. Last but not least, we support the draft resolution. Thank you.
Thank you, Tunisia. Now I give the floor to Timor-Leste, to be followed by Thailand.
Statement for all three diseases in order to save time. Honorable Chair, distinguished delegates, ladies and gentlemen, on behalf of the member state of Southeast Asia region, Timor-Leste makes a joint statement on HIV, hepatitis and STI. Member states of Southeast Asia region recognize and commend the leadership of WHO in developing draft Global Health Sector Strategy 2016-2021 for the three diseases. The strategies are interlinked with Target 3.3, 3.7 and 5.6. They are timeline for the implementation of the SDG target. Universal health coverage is the main driver for implementation of the three strategy. We appreciate that all the three strategies apply similar approach of 5 strategic objectives. We emphasize that functioning primary health care is essential in providing continuum services of the three diseases. The region has made significant progress in controlling the HIV/AIDS epidemic. Between 2001 and 2014, HIV new infection declined by 34%. Test and treat are adopted by most countries in the region. We commit to end AIDS by achieving 000, 0 new infection, 0 death, and 0 discrimination by 2030. A few highlights, Mr. Chair. Continuing investment and concerted effort are needed for the prevention and control of the three diseases. For the countries which are transitioned out from external funding support, they should mobilize and secure domestic funding. For countries relying on external funding, effective coordination are needed. The cost of medicine for the treatment of hepatitis C, such as sofosbuvir, is extremely high, and there is also lack of strategy to promote low-cost generic in all countries afflicted with the level of hepatitis C incidence. We need scientific information for introduction of HPV program, as there are large budget implications. The National Immunization Technical Advisory Group (NITAG) should be strengthened for evidence-based decision. Timor-Leste, on behalf of CIARO countries, fully endorse the draft of global strategy on HIV, viral hepatitis, and STI. I thank you, Mr. Chair.
Thank you, Timor-Leste. Now I give the floor to Thailand, to be followed by Indonesia.
Thank you, Chair. Thailand aligns ourselves with the statement on behalf of SEA countries as delivered by Timor-Leste. We would like to express our concern of the inadequate, comprehensive, and effective surveillance systems on ARV resistance at all levels. Member States must establish such a system with the support from development partners, including the WHO Secretariat, in the line with first strategy on WHO and WHA. On viral hepatitis, one of the most crucial challenges is the unavailability of hepatitis C vaccine. We appreciate the effective coordination of the WHO Secretariat for the expeditious development of Ebola vaccine. We encourage the WHO Secretariat to do the same thing with the hepatitis C vaccine. As these three diseases have the same routes of transmission, we do need a comprehensive package of screening, diagnosis, and treatment for HIV, viral hepatitis, and STIs in accordance to the global health sector strategies. Finally, we adopt the proposed global strategies, but it should not be a one-size-fits-all targets. Member states should implement the strategy and the targets according to their context. The WHO should be sensitive to the evidence from transparent and accountable evaluation in recommending for specific interventions. Member states must build up capacity on economic evaluation of new health technology with the support from development partners, including the WHO, to decide on the best value of money, budget impact, and feasibility of delivery to ensure long-term sustainability. Thank you, Chair.
Thank you, Thailand. Now I give the floor to Indonesia, to be followed by Chile.
Thank you, Chair. Indonesia fully supports statement by Timor-Leste on behalf of share member state. Indonesian delegation would like to thank WHO for facilitating member state in developing the 3 interlinked global health sector strategy on HIV, viral hepatitis, and sexually transmitted infection. Indonesia is committed to eliminating congenital syphilis from mother to child, along with achieving toward triple elimination of HIV and hepatitis B. Indonesia with WHO Shero attended with 11 countries, and WPRO representatives have conducted regional workshop on hepatitis in April 2016, discussing the global health sector strategy on viral hepatitis 2016 to 2021. The workshop has recognized the access to early diagnosis and treatment is crucial. To implement the strategy, the community access to comprehensive and quality health care should be ensured. Support are needed from all government, experts, the private sectors, and all world's community. Participation of the private sector, especially from pharmaceutical companies, are also needed, particularly in securing affordable price of diagnostic tools and drugs, including HBEG. It is impossible to reach elimination without addressing stigma and discrimination. Stigma and discrimination should be especially addressed in the awareness and communication strategy. All action aimed to building awareness should be culturally appropriate and avoid reinforcing stigma and discrimination. We hope that the global health sector strategy on HIV, viral hepatitis, and STI will be implemented in every country in the world. Thank you very much.
Thank you, Indonesia. Now I give the floor to Chile, to be followed by Canada.
Chairman, thank you. I should prefer to speak on the specific item on viral hepatitis, if you don't mind. Thank you.
Thank you, Chile. So you can make your intervention on the viral hepatitis later. So now I give the floor to Canada, to be followed by Germany.
Canada commends the World Health Organization for its efforts to create comprehensive strategy for HIV/AIDS, viral hepatitis, and sexually transmitted infections. These strategies will be important tools to galvanize action and guide our collective efforts towards meeting the Sustainable Development Goals by 2030. We are pleased to co-sponsor the resolution. We are pleased also to see references to controlling the spread and impact of gonococcal antimicrobial resistance in the sexually transmitted infection strategy. An effective public health response requires the prevention of antimicrobial resistance to maintain the availability of effective treatments for sexually transmitted infections. I would also like to reference how pleased we are to see references to harm reduction for people who inject drugs as a key component of a comprehensive prevention package for HIV and hepatitis C. Canada strongly supports drug policy that is informed by solid scientific evidence and uses a lens of public health to maximize education and minimize harm. Canada strongly supports the references in the strategies to the importance of addressing the needs of all key populations. It will help ensure that their rights are upheld, including those that relate to their sexual and reproductive health. This is a question of equity. In closing, Chair, we ask the Secretariat to harmonize and align the accountability and reporting requirements with existing obligations as much as possible. Thank you.
Thank you, Canada. Now I give the floor to Germany, followed by Malta.
Thank you, Chair. My statement is on viral hepatitis. Would you like to wait till you move to the viral hepatitis?
Canada, you can go ahead, or you can wait for the viral hepatitis. Sorry, German.
Okay, then I will make this statement. Thank you, Chair. Germany welcomes the 3 global health sector strategies. We especially welcome WHO's first and timely global health sector strategy on viral hepatitis. The fact that every year the number of people dying of viral hepatitis B and C is equal to the number of people dying of HIV/AIDS is alarming. The strategy, with its interlinkages to the new HIV and STI global health sector strategy, is of even greater importance. We applaud WHO for its strong focus on equity in access to hepatitis services, as well as for its strong emphasis on the role of comprehensive health and community systems. We align ourselves with Australia and Switzerland that UHC is crucial. We call on WHO and all member states to consider the key role of prevention in reducing new infections and hence subsequent treatment costs. Based on individual country contexts, prevention interventions need to include comprehensive harm reduction programs for people who inject drugs, measures to strengthen local health systems, including safe blood transfusion, hospital hygiene and infection control, but also awareness raising and behavior change communication. Further, financial and strategic synergies with other international frameworks for infectious diseases should be identified and used in implementing the WHO Global Health Sector Strategy on viral hepatitis. These include, but are not limited to, the new GFATM strategy and the UN/AIDS Fast Track strategy. We appreciate WHO's strong language on people most affected and at high risk of viral hepatitis. In this context, overcoming stigma and discrimination in the health sector is crucial to allow for equal access to viral hepatitis services. Based on the specific epidemiological and social context, targeted interventions to address stigma and discrimination should be considered among the priority countries' actions to implement the strategy. We appreciate the aim of improving the surveillance system of viral hepatitis, STI, HIV/AIDS, as well as monitoring the prevalence of both hepatitis in the general population and in key population groups. Thank you for your attention.
Thank you, Germany. Now give the floor to Malta, to be followed by South Africa.
Thank you, Mr. Chair. In spite of the rapid expansion of coverage with HIV antiretroviral treatment, with all its beneficial effects on the incidence of new infections, the reduction in deaths and the near elimination of mother-to-child transmission, we are still witnessing changing trends in the incidence of the disease. This is evident with a sharp increase of new infections in the MSM population group. Since last year, Malta has recorded a disconcerting steep rise in new infections in this group, together with a considerable rise in the number of infections in non-Maltese residents from other countries, both from within and outside Europe. In order to address these challenges, a multi-stakeholder think tank was set up last year to develop actions specifically targeting the HIV challenge. A national HIV strategy and action plan aimed specifically at prioritizing these new goals and challenges with specific actions targeting high-risk groups is currently being drafted in consultation with various stakeholders. HIV has also been identified as a priority during Malta's EU Council presidency term in the first half of 2017, whereby we would like to support the action at EU level by proposing a Malta Declaration as a follow-up to the 2004 Dublin Declaration in order to meet today's current challenge in HIV and AIDS. Combining efforts towards joint action and finding innovative solutions to the persistently high costs of diagnosis, prevention and antiretroviral treatment may help in overcoming these major obstacles as well as the achievement of universal coverage. Malta believes that through renewed political commitment, additional resources and technical and pragmatic innovations for the fast tracking of actions and response, the end of the AIDS epidemic can become a reality. Malta welcomes the HIV Strategy 2016 to 2021, presented in document A69/31, and strongly supports its adoption. Thank you.
Thank you, Malta. Now give the floor to South Africa, to be followed by Tanzania.
Thank you, Chairperson. South Africa will address the 3 diseases. In this regard, we support the statements made on behalf of the Africa region on the 3 areas made by Cape Verde, Tanzania, and Mali. South Africa acknowledges We welcome the 3 report, Chairperson, and we acknowledge that viral hepatitis and STI remains neglected despite the importance of STI in HIV infection as well as fertility and pregnancies. Chairperson, the draft STI strategy raises several concerns which we identify with, including lack of awareness of STI, inadequate screening and treatment, and importantly, resistant to cephalosporin, for example. Chairperson, the good news is that there is a vaccine against hepatitis A, B, and E, and it is pleasing that hepatitis C can be cured. However, it is of continuing concern that this is not the case with hepatitis B, which is chronic and requires lifelong treatment. It is critical that the cost of treatment of viral hepatitis is made affordable. We wish to request the DG to use lessons from reducing the cost of antiretroviral used for treatment of HIV to reduce the cost of medicines used to treat hepatitis. Unless this is done, many countries will struggle to provide effective medicine to people with hepatitis. This is also results in our inability to reach the very ambitious target in the global strategy. We welcome the new HIV treatment guidelines, which provide evidence for test and treat as well as pre-exposure prophylaxis. Many low and middle income countries will require ongoing development partner support to fully implement these guidelines. Chairperson, in addition to the need to eliminate gonorrhea, syphilis, and chlamydia, we fully support the focus of the draft strategy on the use of HPV vaccine. However, we are concerned about shortages of penicillin in still high cost of the HPV vaccine. The latter may be somewhat mitigated by the single-dose vaccine. We propose that the DG assist in this regard. Compared to the treatment, much more limited progress has been made with respect to prevention of new infection. A number of new infections, especially in girls and young women in Southern and Eastern Africa, is cause of a major concern. We need to use all our currently known interventions to halt the spread of HIV among this cohort of people which are more vulnerable to HIV infection. It is also critical that research efforts are accelerated with respect to both socio-behavioral as well as research for the vaccine that prevents transmission. The targets set in strategy are steep for high prevalence countries, especially the HIV/AIDS one, but they are necessary as they reflect the sense of urgency that we need to embrace this. Chairperson, in conclusion, we want to support the adoption of the 3 strategies. Thank you, Chair.
Thank you, South Africa. Now I give the floor to Tanzania, to be followed by Saudi Arabia.
Mr. Chairperson, the United Republic of Tanzania is pleased to take the floor on behalf of the 47 member states of the African region on agenda item 15.1, Global Health Sector Strategy for Sexually Transmitted Infections 2016 to 2021. STIs continue to pose a huge health challenge in the African region and impose an enormous burden of morbidity and mortality, both directly through their impact on reproductive and child health and indirectly through their role in facilitating sexual transmission of HIV infection. And hence, we welcome the development of a draft global strategy on STIs. Early diagnosis and effective treatment of STIs is an essential component of STI control programs. The asymptomatic nature of most STIs denies many people access to services. Very few countries have accurate diagnostic tests useful for the diagnosis of asymptomatic infections. While the syndromic management is simple, rapid, and inexpensive, it denies programs in low and middle income countries an opportunity to routinely monitor the specific infections. Syphilis and HIV remain the only STIs with inexpensive rapid tests, yet despite its importance for syphilis, coverage of testing during pregnancy is low. Furthermore, primary prevention has been promoted to reduce the incidence of few infections. In view of the development of antimicrobial resistance of gonorrhea, countries have to invest more on lab diagnosis, including establishing surveillance systems to monitor antimicrobial resistance of different pathogens, including STIs. That this is one of the areas where most of our countries will need support. Mr. Chairperson, improving access to treatment is also a crucial part of the response to STIs. However, access to effective STI medicines continue to pose a challenge, including global shortage on some of important medicines such as penicillin. In view of this, the new global strategy for sexually transmitted infections should provide a framework for countries to improve and accelerate STI programs and ensure that strategies, especially those that can be used to improve access to medicines, screening services, vaccines, and treatment of STIs are operationalized. STIs have traditionally received funding as part of HIV/AIDS programs. However, with the limited funding for HIV and increased demand for ARVs, funding for STIs has significantly decreased. We further recognize that STIs affect all segments of the population, including women and adolescents. Therefore, we call for prioritization and allocation of funding to STI programs as a specific entity and call for adoption of the STI strategy, which takes into account the national context of the diseases and existing national plans. Thank you.
Thank you, Tanzania. Now give the floor to Saudi Arabia, to be followed by France.
شكرا السيد الرئيس.
Thank you, Mr. Chairman. We welcome the draft strategies submitted, and we approve the position set out by Eastern Mediterranean region. The elimination of hepatitis C has become more possible than ever before, as now a large number of prophylaxis are available, even in the advanced phases of the disease. However, we are concerned regarding the difficulty of obtaining the drugs, as these medicines are unavailable in sufficient quantities to stem the outbreaks. There are several solutions, such as the manufacturing of generic drugs of high impact. However, steps taken in this direction have not fulfilled market needs. Some of these drugs, in fact, do not fulfill quality or control requirements. This, in fact, could lead to virus rejection of the drugs. We therefore call on the various members to encourage the production of high-quality generic drugs and to cooperate with other countries, as was the case with AIDS. We would like to remind you of the heavy impact of disease and the fact that many of the patients do not receive sufficient care, and many of them, in fact, ignore that they are carriers of the disease. Thank you.
Thank you, Saudi Arabia. Now I give the floor to France, to be followed by Malaysia.
Merci, Monsieur le Président.
Thank you, Chair. France welcomes the work, considerable work, carried out by the WHO in drawing up these three strategies. These three projects are ambitious and are part of the framework of the SDGs. The international community should not only maintain but also accelerate their efforts to vanquish these diseases. As regards the HIV strategy, which is part of the UN/AIDS strategy, we need to, in its implementation, ensure that we integrate our approaches to avoid separate approaches by disease and have a global response to this health problem. Tuberculosis, which remains one of the major causes of morbidity in people living with HIV, is a striking example thereof. There are 15 million patients that we need to give treatment to by 2020, and this in a context of development in resistance to antiviral drugs. France contributes to these efforts through its commitment to the Global Fund and UNICEF. So we welcome the considerable commitment of the WHO that has allowed them to draw up this global strategy for viral hepatitis, which has general goals of eliminating by 2030 viral hepatitis as a serious threat to public health. This ambition offers great possibilities to act against hepatitis, which give us the opportunity for a real reduction, even eradication of hepatitis C. So, fighting against STIs requires a cross-cutting approach, which we welcome. The focus of this strategy, in terms of universal health coverage, is a demonstration of this, and we are particularly attached to this. France also welcomes the taking into account of antimicrobial resistance and the cost, and the objectives to define and target the most vulnerable populations to ensure equity and efficiency in activities carried out. So we call our member states to adopt these 3 draft strategies, and we thank the Secretariat again for the work it has carried out. Thank you very much.
Thank you, France. Now I give the floor to Malaysia, to be followed by Maldives.
Thank you, Chair. Malaysia would like to address the 3 issues at the same time. Malaysia strongly supports and commends WHO on the initiatives which has been taken in addressing the issues. We welcome the service coverage targets to be reached by 2020 and later on 2030. However, with regard to the treatment of viral hepatitis C, we are afraid that the treatment coverage cannot be reached if the drug prices are still too expensive for these life-saving drugs. We therefore urge WHO to work with other relevant organizations to have effective discussions with the pharmaceutical industry in bringing down the price of these valuable medicines. In relation to the service coverage targets, Malaysia has done all the activities to respond to the agreed indicators. We have launched hepatitis B vaccination for all newborns since 1989. We've introduced HPV to schoolgirls, and we do screening of blood for hepatitis. We have implemented the harm reduction program, including sterile needle and syringes for people who inject drugs. Malaysia supports the draft documents. Thank you.
Thank you, Malaysia. Now I give the floor to Maldives, to be followed by Iran.
Thank you, Chair. We appreciate the documents by the Secretariat. Maldives has a very low prevalence of HIV. Even so, the government of Maldives considers it a priority, and every effort is put in place through the health system to maintain the low prevalence. Mr. Chair, we have learned that globally there have been large declines in new infections and HIV-related deaths. It is indeed promising to see that ending AIDS by 2030 can be made possible, provided that we member states fully implement the fast-track actions recommended for countries as well as WHO. Mr. Chair, Maldives notes the seriousness of viral hepatitis, a significant public health problem for Southeast Asia region. We note that the item 3.3 of 2030 Agenda for Sustainable Development calls for specific action to combat viral hepatitis. Maldives has already achieved significant service coverage in areas such as hepatitis B childhood vaccination coverage, prevention of mother-to-child transmission of hepatitis B, and blood safety, but much needs to be done to reach elimination, which we believe is possible. Mr. Chair, the strategic directions in the new health sector strategy are relevant and realistic, and if fully implemented, a world without AIDS and viral hepatitis may be possible. Finally, we endorse the global health strategy for HIV and viral hepatitis and agree with Thailand they should be adapted according to country needs. Thank you, Chair.
Thank you, Maldives. Now I give the floor to Iran, to be followed by Brazil.
Thank you, Mr. Chair. For the sake of time, I will address the 3 issues together. First, Iran aligns itself with the statement of EMRO, read by Iraq. We appreciate WHO for developing global health sector strategies 2016-2021 and think that AIDS epidemic will be a great achievement for global public health. The current response is neither sufficient nor of necessary speed, and services coverage are not sufficient yet. The location population approach is one of the most helpful recommendations of WHO and UNAIDS in achieving fast-track objectives. The Cascade study is a valuable prototype performed so far, and we request WHO to support that study further and support that study further. As for hepatitis, developing the global health sector strategy for chronic hepatitis aiming at elimination is one of the most valuable actions in line with SDGs. Iran, it is necessary to plan extensively for prevention and treatment of hepatitis to achieve low-price medicines in affected countries. In addition, the strong association between chronic hepatitis and unsafe injection, high-risk sexual behaviors, and injecting drug use all imply that integrating hepatitis and HIV national programs should be seriously considered. Iran has started this kind of integration. The revision of sexually transmitted infections global strategy in post-2015 agenda is one of the most important WHO actions to achieve ending the HIV/AIDS epidemic objectives and ending STI as a public health threat. We would like to ask WHO to promote location population approach similar to HIV/AIDS as a very useful tool for screening STI. We also think that the dilemma of stimulant drug use and increase of STI following high-risk sexual behaviors should be seriously considered in this draft. Integrating STI in the PHC system is a very important achievement, and WHO should support such an initiative. Finally, while we support the draft strategy, we would like to request consideration of sustainable funding for the implementation of such a strategy. Thank you, Mr. Chairman.
Thank you, Ron. Now I give the floor to Brazil, to be followed by Ecuador.
Thank you, Chair. We will address the three strategies in a single intervention. Brazil had the pleasure to host in April 2015 in São Paulo the 2016-2021 consultation on strategies for HIV/AIDS, viral hepatitis, and STIs. We wish to highlight the importance of the draft global health strategies, in particular because they addressed three major public health issues and provide a platform for better coordination, integration, and optimization of resources and efforts to tackle them. We reiterate the importance of prevention, diagnosis, and treatment, as well as promoting and caring for the sexual and reproductive health of all, in particular key populations, within the overarching right to health, especially in countries such as Brazil. As has been the position of the Americas Group, AMRO, we emphasize that the strategies, in particular the one for viral hepatitis, should broadly address people who use drugs, extending beyond the narrower focus on those who inject drugs. Working with the broader category considerably enhances the scope and efficacy of policies worldwide. In relation to viral hepatitis, we congratulate WHO for inclusion of new antivirals in the essential medicines list, as well as the recent development of guidelines for manufacturers of generic hepatitis C medicine. To overcome the challenge of high-cost drugs, including those for hepatitis C, the Ministers of Health of South America agreed in 2015 on a decision to establish a joint large-scale purchasing platform in partnership with PAHO and a database referencing prices in the region. We welcome references to the flexibilities provided by the TRIPS agreement as affirmed by the Doha Declaration on Public Health and Intellectual Property, and as articulated in the principles of the Global Strategy and Plan of Action on Public Health, Innovation, and Intellectual Property as a way to increase access to medicines. As for the sexually transmitted infections, we congratulate Cuba for being recognized by the Director General of WHO as having achieved eradication of mother-to-child transmission of HIV and syphilis. Brazil is committed to working nationally and within a PAHO-supported regional initiative to meet this important health goal. The success of public policies, however, now hinge on overcoming a global shortage of penicillin. We need to urgently discuss this issue to avoid situations of future such shortages, and we therefore thank the United States and South Africa for taking the initiative of bringing the issue to the attention of the Assembly under item 16.4 of the agenda. We hope we can finalize the resolution text to the satisfaction of all member states. Finally, we express our grave concern with the recent arbitrary increases in the prices of drugs for opportunistic infections related to HIV/AIDS. a trend which has negatively impacted treatment for those most in need, vulnerable groups, and key populations, hampering public health policies seeking universal coverage and access to medicines and health services and treatment, leaving no one behind. Thank you.
Thank you, Brazil. Before giving the floor to Ecuador, there is an announcement from the Secretariat. An informal meeting will be held in room 23 at 11:20 to work on the draft resolution contained in document A/69/B conference paper number 3, revision 1, on addressing the global shortage of medicines. So I announce again that there will be an informal meeting of a conference paper of global shortage of medicines at 11:20 in room 23. Thank you. So now I give the floor to Ecuador, to be followed by Mali.
Thank you, Chairman. We support the AGRUA statement. We are determined to bring an end to the epidemic as a public health threat by 2030. In order to save time, I'm not going to read the statement of my delegation, but I would like you to note, sir, that Ecuador does support the strategy 2016 to 2021. Thank you.
Thank you, Ecuador. Now I give the floor to Mali, to be followed by Papua New Guinea.
Merci, Monsieur le Président.
Thank you, Chair. Mali is honoured to speak on behalf of the 47 African region states. And we would like to say here that the outcomes from the period of implementation of the MDGs is notable. However, this new strategy, 2016-21, is arriving at the right moment because we're then implementing the MDGs, SDGs. So with this, we need to take into account that the committee that worked on this issue, issues regarding multi-sectoral approach and taking into account and learning lessons from the MDGs in terms of activities, long-lasting activities, and also put health at the heart of the debate. We'd also like to draw your attention to the need to play focus on particularly most vulnerable groups, such as sex workers. And we'd also like to see that the definition of target groups will be left to states according to their individual context. And although the issue of availability of vaccinations is highlighted, which is particularly important for the African region, and also behaviour issues through community interventions, this needs to be highlighted as well. Financial viability, finally, in terms of implementing the strategy, needs to be considered widely to be able to look at sustainable options. However, solidarity is already implemented, and this needs to continue to facilitate the progressive implementation of domestic funding mechanisms. Also, the African region invites all parties to commit during the next high-level AIDS meeting in 2016. Because of the pertinence of the strategy and the proposals, the African region supports the strategies and would like to see it approved by our Assembly. Thank you very much.
Thank you, Mali. Now I give the floor to Papua New Guinea, to be followed by Vietnam.
Thank you, Chair. Papua New Guinea appreciates and commends the efforts of the Secretariat in providing this comprehensive draft global health sector strategies of HIV, viral hepatitis and STI 2016-2021. So these are very important strategies for my country. Of the 22 Pacific Island countries and territories, we have the highest burden in that region, and also one of the highest in WIPRO. And so we appreciate these strategies, and we will need support and help so that we can integrate and complement into our own strategies what we see would be fit for us. So we need a lot of help on that. I will be talking on the three diseases, just highlighting to give us the flavor of what the situation is in PNG. PNG has a concentrated epidemic at 0.8% prevalence, but we are looking forward to the integrated biobehavioral surveillance on our key populations underway, which will help us to give more clarity on the true burden of this challenge and help us to guide the formation of our next 5-year HIV/AIDS strategy. Chair, by the end of 2015, 60% of our people living with HIV/AIDS were on treatment. The number of new infections is dropping from 5,000 to below 3,000. The number of deaths reduced by 50% and forecasted to continue to drop. For STI, PNG reports only by syndromic diagnosis. So we need a lot of help to get us through to the actual diagnosis that we are wanting to see. From recent limited data, it showed that there's regional differences in our country, as high as 66.3% to 8.8% in some of our settings. For hepatitis B, not much data is available, but recent national survey prevalence was around 10% in some of our provinces. Birth dose vaccination of hepatitis B is at about 25%. Our blood bank services have started hepatitis C screening, but yet there needs to be scale up that we are working on. Chair, PNG noting the targets identified in transforming our world, the 2030 Agenda for Sustainable Development on HIV, viral hepatitis, sexual and reproductive health, and universal health coverage supports the call to adopt the global health sector strategies on HIV, viral hepatitis, and sexually transmitted infections for this period 2016 and 2021. Thank you, Chair.
Thank you, Papua Nikini. Now I give the floor to Vietnam to be followed by Jamaica.
Thank you, Mr. Chair. Vietnam welcomes and supports the 3 draft global health sector strategies on HIV, viral hepatitis, and STI. Regarding the HIV prevention and control, the global strategy will guide us optimize the strategic priorities, including increasing domestic resources for the national HIV response, prioritizing the essential and high-impact interventions, promoting innovations, HIV cell testing, and immediate treatment, especially for the key populations, pre-exposure prophylaxis, integrating and decentralizing HIV service delivery. In the framework of universal health coverage with helpful WHO technical assistance, we recognize that further efforts will be needed to fast-track ending HIVs. In terms of viral hepatitis, Vietnam would like to request the WHO Secretariat support surveillance system of hepatitis virus and find a mechanism to access to cheaper price medicines for HPV, HCV. With regards to STI strategy, Vietnam would suggest following prior points. First, we need to show the effectiveness for the STI program in prevention of STI, HIV, cancers, and even the cost effectiveness in order to be easier to ask for the funding. Second, WHO recommends better accuracy and cost for STI diagnosis in surveillance, including drug resistance. Third, WHO have to find cheaper HPV vaccines so people can afford. And fourth, more vaccines for other STIs. Thank you, Mr. Chair.
Thank you, Vietnam. Now I give the floor to Jamaica to be followed by Bahrain.
Thank you, Chair. Jamaica likewise will merge comments on the 3 documents. We wish to commend the WHO Secretariat for providing the comprehensive draft Global Health Strategy for HIV 2016 to 2021. This strategy aligns well with Target 3.3 of the 2030 Agenda for Sustainable Development adopted by the UN General Assembly to end the AIDS epidemic by 2030. Jamaica has made significant strides in the HIV response. It was estimated that as at the end of 2014, there has been a reduction in new infections over the decade. Approximately 81% of persons living with HIV are estimated to be aware of their HIV status, and HIV prevalence has been less than 2% for more than a decade. MTCT rates are below the elimination target of 2%. These successes have been achieved with significant support from international donor agencies. While the investment case for the HIV program is a priority and Jamaica has already adopted universal health care, tight fiscal space prevents easy maneuverability to increase financing for the program expansion through increased taxation and budget reallocation. Financial support to countries facing such economic constraints must continue as we engage implementing partners and civil society organizations to maintain and improve the gains made well into 2030. With respect to viral hepatitis, Jamaica urges WHO to provide support to countries, including Jamaica, to assess or define their burden of viral hepatitis. Emphasis should be placed on Priority Action 1, Information for Focused Action. Jamaica has limited data on its burden of viral hepatitis. The data available is outdated and limited to hepatitis B. Improving data availability for all forms of hepatitis is critical for program planning. The introduction of hepatitis B vaccine in Jamaica in 2003 is expected to have a significant impact on the burden of hepatitis B in the long term. Coverage rates for infants has been 90% or more since 2009. However, investments in the prevention and control of all types of hepatitis B will be required post-assessment. Chairman, Jamaica endorses the draft Global Health Sector Strategies recommended by the Executive Board. Thank you.
Thank you, Jamaica. Now give the floor to Bahrain to be followed by Philippines.
Thank you, Chair. I would like first and foremost to express my thanks and appreciation to the Director General and all those in charge of drafting these strategies in the health sector regarding AIDS for the period 2016-2021. We'd like to express our appreciation and support the statement of EMRO. We also support the statement made by Saudi Arabia. Bahrain has abided by the agreements concluded within the framework of UN and have established national committees to combat the disease. This includes representatives of all authorities. We have established a strategy based on the UN strategy, the WHO multi-sectoral strategy. We have included the private sector, civil society, those living with AIDS and those infected by AIDS. In our consultative council, we have adopted a decision on the matter. The Kingdom of Bahrain is aware of the heavy burden of hepatitis B and SDIs on public health. We have taken clear steps and included vaccine and encouraged the use of single-use injections to reduce the spread of the disease. All newborns are vaccinated against hepatitis, and all blood products are examined against all viruses, whether they be hepatitis or SDIs. Pregnant women are also, in fact, examined to avoid transmission to newborns. Also, young people and persons about to wed are examined for the diseases. The Kingdom of Bahrain supports the steps taken by the Secretariat to combat these viruses. We also support all steps in the draft strategies regarding viral hepatitis, HIV, and sexually transmitted infections. We wish once again to commend the statements made by EMRO and the Kingdom of Saudi Arabia. Thank you, Chair.
Thank you, Bahrain. Now I give the floor to Philippines, to be followed by Rwanda.
Mr. Chair, as with other speakers, we appreciate the great work done by the Secretariat in coming up with a draft Global Health Sector Strategy for HIV, viral hepatitis, and STI. We noted that while HIV is declining globally, it is increasing in some countries, which include the Philippines. We also noted that viral hepatitis is a growing cause of mortality among people with HIV and also responsible for 1.4 million deaths. We also noted that high prevalence of STI, which could have profound impact on children, adolescents, and adults worldwide. We are committed to reverse this trend. We emphasize that strong combination of health system strengthening, cost-effective public health approaches, and continuum of services are essential for effective HIV, viral hepatitis, and STI response. In view of this, the Philippines supports the adoption of the 3 draft global health sector strategies, which will provide member states with evidence-based interventions and guidance for their respective programs as appropriate with countries' national circumstances. Thank you, Mr. Chair.
Thank you, Philippines. Now I give the floor to Rwanda, to be followed by USA.
Thank you, Chairman. Rwanda fully supports the statement made by the African countries on behalf of the African WHO region. We thank the Secretariat for the developed 3 strategies, HIV, viral hepatitis, and STI strategies 2016-2021. We would like to call the WHO Secretariat to consider supporting the countries to implementing these plans, not as a vertical programs, rather as a part of comprehensive and integrated patient-centered care. Specifically, Rwanda welcomes the HIV strategy and has committed to move forward with the strategy from July 1st, 2016. We have planned to start test and start strategy at national level to fully maximize the drug's impact at reducing AIDS-related morbidity as well as the new HIV incidences. However, we call for attention for allowing the reduced international support for low-income countries and other limited resources countries in the fight against HIV and other infectious diseases. We urge the WHO Secretariat to advocate for sustained financing support as the countries develop and reach the sufficient level of domestic resources to take over with the financing of the HIV and the infectious disease program. We recommend the use of national systems and the transitioning from vertical to horizontal support that is proven to build a resilient and sustainable health system for countries. Thank you.
Thank you, Rwanda. Now I give the floor to USA, to be followed by Estonia.
Thank you, Mr. Chair. I would note that we have consolidated our comments on these 3 strategies into one statement. WHO's work in HIV, hepatitis, and sexually transmitted infections is vital. The strategies are well aligned with the Sustainable Development Goals and the UNAIDS 2016 to 2021 Fast Track Strategy, and to each other. The Fast Track approach front-loads key investments and maximizes efficiencies. Increased domestic investments will be critical to their success. We would like to draw special attention to the following points. First, the importance of more efficient and differentiated service delivery models. Greater adherence and retention across the treatment cascades are needed. So is a focus on reducing the risk of HIV drug resistance. Untreated drug use and mental disorders can adversely affect adherence. Second, member states should clearly articulate how they will reach all key and vulnerable populations, including men who have sex with men, transgender people, sex workers and their clients, people who inject drugs, and prisoners. Girls and young women are especially vulnerable, but we must also address how to reach their partners. Third, greater emphasis is needed on cost studies. Optimal use of program and financial data can lead to better prioritization, implementation, and forecasting. A warning on the complexity of these issues. For example, promoting affordability and access to medicines are important shared goals, but some of the methods advocated in the strategies could result in unintended consequences. IP is only one component of access and could be important in the development of new medicines. Many other factors influencing access are not addressed in the strategies, but also should be considered. Finally, the word advocacy is used numerous times in the strategies. WHO's reputation as a neutral convening body trusted by all. Advocacy needs to be for best evidence in implementing guidelines. Thank you, Mr. Chair.
Thank you, USA. Now I give the floor to Estonia, to be followed by Suriname.
Thank you, Mr. Chair. Estonia thanks the WHO Secretariat for its hard work on the global health sector strategy for HIV. We support the strategy and the ambitious targets within. There is a renewed momentum in the fight against HIV/AIDS in the UN/AIDS strategy, the global health sector strategy we're discussing now, and the action plan for HIV in the WHO European region, to be discussed at the Regional Committee for Europe this September. We appreciate the close cooperation shown in the development of these documents. HIV/AIDS continues to be a considerable health challenge for Estonia. We are currently focusing on ensuring that all people living with HIV know their status through expanding testing at primary healthcare level. Comorbidities pose another challenge, requiring a holistic patient-centered approach. We are currently offering combined services for HIV and TB, as well as HIV and opioid substitution therapy. All harm reduction services are fully funded from the state budget, and we are looking to further expand their coverage in the future. HIV epidemics in different regions have different context. The European region is the where the number of new infections is still growing. Injecting drug use still accounts for almost half of all new HIV cases in Eastern Europe and Central Asia. This epidemic cannot be stopped in the region without harm reduction and access to healthcare and social services. We call on WHO to provide assistance to member states in this regard. Finally, we note that the unified format of the global health strategies is a welcome innovation to WHO's policy documents. We encourage WHO to continue developing and using common templates for other types of policy documents in the future. Mr. Chair, Estonia supports the strategy and the adoption of the resolution contained in document A69/59. Thank you, Chair.
Thank you, Estonia. Now I give the floor to Suriname, to be followed by Senegal.
Thank you, Mr. Chair. The delegation of Suriname would like to compliment the Secretariat with the draft global strategy for HIV. We were happy to see that many of the issues identified during the past years in the response to reduce HIV were mentioned. Suriname, in line with the 1999 targets, has also committed itself to reaching these targets by including them in the National Strategies Plan 2040-2020. An important issue mentioned in the draft global strategy is the monitoring of progress, and Suriname is glad to see one of the fast-track actions for WHO mentioned in the document is to provide monitoring tools. In this regard, Suriname does want to urge Secretariat to provide country-specific guidance in adapting tools, as experience learns that one size does not fit all, and countries are in different stages of implementation. We were glad to find in the report that there is a need to integrate in health services related to other diseases such as hepatitis, TBC, non-communicable diseases. We as country look towards the Secretariat for guidance for the implementation. Suriname supports the draft Global Health Sector Strategy for HIV as presented, but would like to urge the Secretariat to help countries secure funding and technical assistance for implementation, not only for key populations, but also for other vulnerable groups as mentioned in the strategy. Thank you.
Thank you, Suriname. Now I give the floor to Senegal to be followed by Slovakia.
Thank you, Chairman. Chairman, ladies and gentlemen, Senegal would like to congratulate WHO for including this strategy. Fighting against the HIV pandemic is something which we have to do decisively, bringing an end to the HIV epidemic as a public health threat between now and 2030. However, we certainly haven't won yet. Access to care remains very limited still among key groups in some regions, and the ability to quantify the viral load is something requiring technologies and techniques not always available. Comorbidity, particularly with cancers and cardiovascular diseases as well as viral hepatitis, need to be tackled in an integrated way, and the way in which we tackle them needs to be adapted to the circumstances of each country. That's particularly true of co-infections with viral hepatitis B and C. On care of patients with hepatitis, we have to take additional action in areas such as access to care and diagnosis. Senegal is trying to do that and supports the current draft Global Health Sector Strategy 2016-2021 for that reason. In addition to its adoption, we hope that we can have a unit to monitor its full implementation in the various WHO regions. Thank you.
Thank you, Senegal. Now we give the floor to Slovakia to be followed by Greece.
Thank you. Dear Mr. President, Slovakia would like to thank the Secretariat for its hard work on all the strategies within this agenda item. Slovakia supports Japan, China and Malta's comments on the role of prevention at local level and local sensitivity or local wisdom. Situation in some countries and regions shows that STI and risky behavior prevalence can be less prevalent than in other countries or regions because of effective prevention. We should not deal with concerns only, but to promote awareness of positive values and positive attitudes, including responsible, mature relations, family, parenting skills, and responsible, healthy relations in family, relation of children, parents, couples. We also consider important prevention of promiscuity and risky behavior on the basis that such lifestyle can lead to vulnerability, poverty, and poor health, and on the other hand, promotion of protected environment and values for children and adolescents as a basis of STI and mental health prevention of future generations. Serbia proposes to WHO Secretariat to consider further work in collecting best practices, examples of healthy lifestyle support and local wisdom, and prevention approaches to STI and high-risk behavior prevention in different regions and countries within STI agenda, also within developing global adolescents health agenda. Dear Mr. President, we have heard in the WHA side event on NCDs that healthy lifestyle and prevention solutions are 4 times less costly than treatment. Slovakia looks forward to further discussions on this important issue and offers to share its best practices of education of parenting skills and positive values and attitudes. Thank you.
Thank you, Slovakia. Now I give the floor to Greece, to be followed by Nigeria.
Thank you, Mr. Chair. The idea of developing a national hepatitis plan that included a specific agenda to find ways to treat all persons living with chronic hepatitis C with the treatment they need, so also with the latest generation of medicines, is something that our government and specifically our ministry decided to make formal in a public declaration at WHO Executive Board meeting. Greece made a statement on the WHO's Global Health Sector Strategy on viral hepatitis, which our government endorses as the strategy for HIV and Hep B. The Greek statement clarified government's commitment in ending viral hepatitis in Greece, collaborating with EU, WHO and other partners in its response to hepatitis and learning from countries currently embarking on elimination of HCV. The moral dilemma of a society with limited resources due to externally imposed constraints that considers every person's right to proper treatment must be resolved. The solution lies in a combination of measures regarding prevention, harm reduction, inclusion criteria to new therapies based on prioritizing needs and control of the spread of disease. Political commitment is given. Patient records, the practice of extensive diagnosis by calculating the annual number of patients to be treated, and the price through negotiations of the new innovative medicines based on the existence of a national action plan with a concrete timetable and utilization of HTA, risk assessment and joint procurement are valuable tools. Consensus and the participation of patients and society in the critical and delicate prioritization decisions are necessary components of such a policy. Moreover, the exchange of expertise and experience across countries could prove an equally essential feature. Developing and implementing a national action plan is a considerable task on its own right, but it is our top priority, and we firmly believe that with hard and efficient work and the solid assistance of WHO, we can tackle the HCV epidemic. Thank you, Mr. Chair.
Thank you, Greece. Now we give the floor to Nigeria, to be followed by Poland.
Okay. Thank you, Mr. Chairman. Nigeria would like to align itself with the Afro region and then to thank WHO for these 3 strategic documents. And then we would like to talk on the 3 issues, both viral hepatitis and then STIs. Nigeria has aligned itself with the Afro position, adopting the 1990 targets for 2020, and the push and test directive has been given for people living with HIV, and the PMTCT that has also been adopted for use as a for lifelong treatment for women that are pregnant. Then for hepatitis, for the viral hepatitis, especially B and C, there's a national viral hepatitis control program that has been adopted since 2013 with strategic documents developed. There's a strategic plan with a policy in line with the WHO adoption of World Health Assembly 63.18 of 2010. And then for the STIs too, there's a national strategic plan in place with a minimum intervention package in place. But above all is instead of all these parallel programs, it needs to be a comprehensive and integrated approach to this so that we can leverage on things like strengthening of the health system in order to expand its capacity and then to accommodate whatever pressures that will come in so that it will minimize resource utilization, and then to build in local capacities, because for countries like mine and then in the region, we're largely dependent on development partners and other developed countries. So they need for in-country capacity development, sourcing for funds, and then in a way so that the system can be strengthened. Now, there is the Abuja Declaration, which there needs to be commitment, especially in the region, for its full implementation. And for funding, apart from in-country domestic resource, I think we need to open up the space for public-private partnerships, and then we should expand the scope, looking at social health insurance and as a component of achieving the universal health coverage. So in line with this, Nigeria would like to join the full region and the other WHO member states to adopt this resolution. Thank you, Mr. Chair.
Thank you, Nigeria. Now I give the floor to Poland.
Thank you. Mr. President, dear colleagues, we would like to thank the Secretariat for the work on the 3 strategies done. We fully support them. To be brief, we would like to echo the statement made a few minutes ago by Slovakia. Thank you.
Thank you, Poland. That's very short and precise. So that's all for the list of speakers from the first round on the first strategies. I will now invite those member state delegations who have not delivered their statement on either viral hepatitis or sexually transmitted strategies to do so. Thank you. So I now give the floor to Chile.
Chairman, thank you. We'd like to thank the WHO Secretariat for its report on the draft strategies to control and prevent viral hepatitis. Chile agrees with what is stated in the document and with the strategies proposed. We would like to mention the following progress we have made. 5 years ago, we developed a strategic plan for the prevention and control of hepatitis B and C. We provide vaccination since 2005 to all newborns and those who are in groups at risk, health staff, patients under hemodialysis or with hepatitis C, HIV/AIDS sufferers, sex workers, transsexual persons, and others. We also provide guaranteed for and follow-up of treatment for hepatitis B and C in the public and private health system. Furthermore, we have clinical guidelines on hepatitis B and C treatment and other guides which are helpful for those managing the illnesses in the health system. Furthermore, through a supplementary assistance program, we have access to new therapies for treating hepatitis C, and we're grateful for Brazilian support in gaining access to drugs. We agree with the document and the draft global strategies to prevent and control viral hepatitis. Of course, the epidemiological features of them and causes of transmission vary from country to country. Thank you, Chairman.
Thank you, Chile. I have no more speaker on my list. So, and several governmental organizations and observers in relation to WHO have requested the floor on this sub-item. I shall now give the floor to representative of Chinese Taipei, to be followed by UNS.
Thank you, Chair. Chinese Taipei appreciates WHO's effort in setting targets for viral hepatitis, HIV/AIDS, and other sexual transmitted infections. Last year, we participated in the online survey for the global health sector strategies and proposed several suggestions. We applaud WHO Secretariat's report on the strategies for 2016 to 2021. Although our 3-dose hepatitis B vaccination coverage for infants has already reached 97% in 2015, We continue to conduct hepatitis screening campaigns to identify the infected and carriers and to provide treatment for all those in need. The hepatitis B and C treatment program, launched in 2003, has significantly reduced the mortality rate of chronic liver disease and cirrhosis. However, resources for chronic hepatitis treatment and care are still cost prohibitive under universal health care. Regarding HIV/AIDS, in an effort to achieve the shared vision of zero discrimination, in 2015, we amended the regulation of travel restriction on the entry and the residence of people living with HIV/AIDS. Meanwhile, to better prevent, detect, and treat congenital syphilis, we listed congenital syphilis as a notifiable disease in April 2016. Surveillance of congenital syphilis provides us better understanding of the magnitude and the trend of the disease, which is in line with WHO's target to eliminate congenital syphilis. WHO's target reminds us not to be satisfied with our current achievement, but to continue to work on prevention and control of viral HIV/AIDS and sexually transmitted infections. Thank you.
Thank you, Chinese Taipei. Now I give floor to UNAIDS, to be followed by International Federation of Red Cross and Red Crescent Societies.
Thank you, Mr. Chairman. UNAIDS welcomes the opportunity to speak in support of WHO's Global Health Sector Strategy on HIV. Immediately after the international community adopted the Sustainable Development Goals in the United Nations General Assembly in September 2015, including the goal to end the AIDS epidemic by 2030, the UNAIDS Programme Coordinating Board in October 2015 adopted the UNAIDS Global Strategy on AIDS for 2016 to 2021. The UNAIDS strategy, which is fully aligned with the SDGs, includes key goals and targets with a view to fast-track the AIDS response in the next 5 years. Most importantly, it establishes the foundation for an evidence and rights-based approach to ending the AIDS epidemic. The WHO HIV strategy is a key component of the multi-sectoral AIDS response set out in the UNAIDS strategy. It incorporates ambitious but realistic targets agreed by member states. It fully harnesses the potential of the health sector in bringing HIV prevention and treatment services to all people, including vulnerable groups, and ensuring that no one is left behind. We are at a time when rapid acceleration of HIV sources have averted millions of new HIV infections and AIDS-related deaths. Thanks in large measure to investment in integrated, people-centered health services, the dedication of the health workforce, and the mobilization of civil society. The new WHO strategy is fully in line and harmonized with the UNAIDS strategy, and we look forward to its adoption by this Assembly. UNAIDS will continue to work closely with WHO, one of its co-sponsors and closest partners, to implement the strategy and fast-track the AIDS response. In just a few days, the United Nations General Assembly will hold a high-level meeting on ending AIDS in New York from 8 to 10 June. In that meeting, the adoption of this WHO strategy will send a strong signal of the continued commitment of Ministers of Health to the AIDS response, to ending AIDS as a public health threat by 2030, to addressing HIV-related stigma and discrimination in all societies, and improving health and well-being of all people living with and affected by HIV. Thank you, Mr. Chair.
Thank you, UNAIDS. Now I give the floor to IFRC, to be followed by
Chairman, could we have the speaker's microphone, please? Thank you.
IFRC. Can you start again, because the microphone doesn't work?
Thank you. The IFRC reaffirms its support to the 2030 Agenda for Sustainable Development, including commitment to end the AIDS epidemic by 2030. We welcome updated HIV strategy 2016-2021, which will be essential to end AIDS by 2030. Upcoming United Nations General Assembly on the fast track to end AIDS, taking place in June, is the major opportunity for member states to pledge and intensify efforts to end AIDS by 2030. We welcome also the Zero draft declaration that contains strong messages on key issues and includes a number of clear targets and commitments that we would like to see in the final documents of high-level meeting, as well as the final version of the strategy 2016-2021. Specifics focus on needs and rights of each key population group, to reduce transmission of HIV among people who use drugs, concrete ways forward for the meaningful involvement of people living with HIV, communities and affected groups, and the barriers that needs to be removed, needs for affordable HIV treatment for all people who need antiretrovirals and do not have access to them, need a commitment from member states and donors to fully fund the global AIDS response. From our side, the IFRC and Red Cross and Red Cross societies are uniquely placed to assist. Our volunteers are drawn from the communities they serve, and our societies enjoy a privileged relationship with governments as auxiliaries in humanitarian and health-related matters. Collectively, we must find a way to make this goal a reality and expand our health system to ensure no one is left behind. Thank you very much.
Thank you, IFRC. So now I give the floor to Kawi.
Thank you, Chair. I have prepared a statement for item 15.2. Do you want me to deliver that now?
Please.
He said yes. Thank you, Chair. As a global public-private partnership, Gavi, the Vaccine Alliance, brings together key stakeholders in immunization. As we are now at the midpoint of the decades of vaccines and the goals set out, it is time to build on the progress made and address the challenges ahead. While progress has been made in a number of countries on the GVAP targets, the decade of vaccines is not on course to achieve its true potential. While the GVAP target for new vaccine introduction is on track to be met, demonstrating country leadership and commitment to introduce life-saving vaccines into routine immunization systems. However, much more work is needed to get back on track to reach the remaining goals. Global average coverage for measles first dose has remained stagnant over the past 5 years at 85%, well below the coverage required to control, let alone eliminate measles. We must join efforts to achieve sustainable measles control before embarking on eradication. Reaching underserved population with life-saving vaccine is especially challenging, even more so in the context of humanitarian crises. While the GVAP does have clear goals for coverage and equity targets, the plan does not explicitly how to do this. In this context, in this next half of the decade, we need to emphasize coverage and equity in order to ensure that the key targets are achieved. As part of Gavi's new strategy, Gavi will be working with countries to prioritize investment to address coverage and equity. In parallel, the Secretariat is working to streamline and strengthen Gavi's country engagement model to increase effectiveness and efficiency. By 2020, it is estimated that nearly 20 countries will transition out of Gavi support. As such, Gavi will increase its efforts to work with countries to plan for transition to help programmatic sustainability of immunization systems. We also recognize country calls for support to sustainable pricing levels in line with Gavi price levels. The current policy supports countries accessing Gavi tenders, where manufacturers are able to offer Gavi prices for 5 years after transition. Some manufacturers have announced an additional 5 years for specific vaccines, allowing for stable prices at Gavi price levels for 10 years in some cases.
Furthermore, as the recent yellow fever outbreak and Ebola crisis have demonstrated, an equal emphasis is needed on building sustainable health systems in countries and an international approach on ensuring vaccine access in the event outbreaks occurred. The Sustainable Development Goal Monitoring Framework, which is still under discussion, provides an excellent platform to reinvigorate the global commitment to GVAP. Gavi continues to advocate for the inclusion of a GVAP-aligned immunization indicator in the SDG monitoring framework and call on member states and partners in this room to join us in this important effort. Finally, we must continue to adapt, to innovate, and at the same time to get back to the basics of building strong health systems which will lead to greater global health security. Gavi stands ready to play an integral part in this process. I thank you, Mr. Chair.
Thank you very much, Gavi. Gavi, we have noted your statement is related to 15 on GWAP and also with many related issues on these 3 global strategies. So we will take note of your statement in this occasion. So I now give the floor to Philippines.
Thank you, Mr. Chair. We welcome the Secretariat's report on progress towards achievement of global immunization targets. We note that although there have been progress, there are also concerns of challenges that still remain in the areas of vaccine coverage.
It would be in the next agenda. Philippines.
Right. Our apologies.
Sorry about that. So. Sorry for this confusing because Gavi intervention is related to also in the GWAP and also with these 3 global strategies. So we will continue with on the 15.1 of the draft global health sector strategies with statement by a number of non-governmental organizations. So now I give the floor to Global Health Council, GHC, to be followed by International AIDS Society.
Thank you, Chair. GHC, with the Elizabeth Glaser Pediatric AIDS Foundation, welcomes the HIV strategy and is called for renewed political commitment, additional resources, and technical and programmatic innovations. We are especially pleased the strategy prioritizes eliminating mother-to-child HIV transmission as a key component of ending the epidemic. We strongly encourage countries to increase their efforts to eliminate vertical transmission, focusing on access to prophylaxis for infants and adherence for support in the breastfeeding period, when 60% of child infections are now occurring. We also encourage states to pursue WHO certification of elimination to ensure sustainable systems are put in place. We also applaud the strategy's attention to pediatric treatment and its message that infants, children, and adolescents are among those who have suffered the greatest inequities in access to treatment. African health ministers recently proposed a target of putting 95% of children on treatment by 2018. We ask states to pursue this ambitious goal by intensifying efforts to diagnose children, initiate them on treatment, and support their long-term adherence. As the strategy says, we need expanded coverage of early infant diagnosis, innovation of simpler and more palatable pediatric ART formulations, and better and earlier linkage to treatment. Finally, we support the strategy's proposal for differentiated models of treatment and care, but would add that models should also differentiate by age groups, taking into account the specific risks of poor adherence, treatment failure, and loss to follow-up among infants, school-age children, and adolescents. Thank you.
Thank you, Global Health Council. Now I give the floor to International AIDS Society to be followed by International Federation of Medical Students Association.
Chairperson, distinguished delegates, good morning. The International AIDS Society welcomes the global health sector strategies and congratulates the WHO on the broad-based consultation process. HIV, viral hepatitis and STIs are major public health issues, and an integrated client-centered approach within a framework of universal health coverage will strengthen achievement of the SDGs. The successful implementation of these strategies will depend, however, in part on a motivated and capacitated healthcare workforce. The HIV strategy in particular recognizes that despite advances, inequities remain between and within countries and population groups. The particular focus on key population across various epidemic scenarios and adolescents, notably young women and girls, is an important element that we urge continued focus on, while also ensuring accessibility of scientific advancements, especially around prevention. The viral hepatitis strategy proposes the first ever global targets towards elimination of viral hepatitis by 2030. While the goals are ambitious, we believe they are imminently attainable. Advances can be made by linking with other programs through the management of, for example, HIV co-infections and by advocating for reduced drug pricing. The STI strategy promotes synergies and integration of sexual and reproductive health and rights and HIV services. The links between HIV and STIs are well established and recognized, but solutions must ensure that men and boys in particular access these linked services as healthcare recipients. The International AIDS Society encourages the WHO to continue to act on the interconnectedness of the three strategies, especially for overlapping key populations and service delivery modalities and needs. The International AIDS Society also commits to involve our broad membership base of frontline healthcare workers to support implementation of the global health sector strategies. Mr. Chairperson, thank you.
Thank you, International AIDS Society. Now I give the floor to IFMSA.
Thank you, Chair. Distinguished delegates, the International Federation of Medical Students Associations, IFMSA, has for a long time emphasized and pushed forward strategies on zero tolerance towards ignorance-fueled stigma and discrimination in healthcare against those living with HIV, hepatitis, or any other STIs, and would like to congratulate the creation of the global strategy on these topics. We strongly believe the draft strategy offers a framework for member states to implement best practice healthcare from a people-centered, holistic and human rights approach that ensures a healthy livelihood and promotes the well-being of those affected or at risk of being affected by HIV and other STIs. IFMSA, as of the Pact, a UNAIDS youth constituency, wants to reaffirm that actions to end AIDS by 2030 will require an increased effort and sustainable investment in the field. We are still far from achieving our goal, but broad intersectoral partnerships and involvement of civil society organizations as important actors in efforts can help enormously. As an organization with a strong focus on sexual and reproductive health and rights, we encourage in particular comprehensive sexuality education as a method in order to reach and protect those most vulnerable and at risk, particularly young people. We oppose any action by member states to restrict young people's access to education and information regarding their sexual and reproductive health. We must take rapid action to end AIDS, hepatitis, and other STIs by 2030 and ensure that no one is left behind. Thank you for your attention.
Thank you, IFMSA. Now I give the floor to International Planned Parenthood Federation, to be followed by Medicine Sans Frontier International.
Thank you, dear Chair. I thank you for giving the International Planned Parenthood Federation the opportunity to address the WHA. We welcome the draft health sector strategies on HIV, viral hepatitis, and sexually transmitted infections, and support the emphasis of all three of these strategies on equity, financing, information, impact, and innovation. We also welcome the emphasis on gender equality and human rights as fundamental principles on which these strategies are based. We are encouraged by the linkage of these strategies to sexual and reproductive health and are optimistic that the greater integration and linking of HIV, viral hepatitis, and sexually transmitted infections will help to ensure universal access to sexual and reproductive health care services. The greater integration of services and programs has the potential to reduce costs, improve efficiency, and lead to better outcomes. We particularly welcome the draft Global Health Sector Strategy on sexually transmitted infections, which can have a profound impact on the sexual and reproductive health and well-being of all, with complications disproportionately affecting women. A renewed global focus on key infections, such as syphilis, gonorrhea, and human virus, has the tremendous potential to mitigate the often hidden impact on stillbirth, cervical cancer, HIV transmission, and infertility worldwide. For these ambitious strategies to become a reality, it requires political support, financial investment, and integrating with existing health systems, including community-based service providers. We call on the member states gathered here to show the leadership that is required in all fora, including at the high-level meeting on ending AIDS in New York in June. In particular, we call for full funding for the Global Fund through the replenishment event in Canada in September. IPPF fully supports the adoption of these draft global health sector strategies by the 69th World Health Assembly. Thank you, dear Chair.
Thank you, IPPF. Now I give the floor to Medicine Sans Frontières International, to be followed by Medicine Parenthood Foundation.
Thank you, Chair. Médecins Sans Frontières, MSF, welcomes WHO's Global Health Sector Strategy on HIV and urges member states to rapidly adopt and implement WHO's HIV guidelines, particularly the recommendation to provide antiretroviral therapy to all people living with HIV upon diagnosis. Evidence shows that treat all policies, also known as test and treat, can decrease the risk of developing AIDS by 57%, reduce the risk of sexual transmission by 96%, and give most people living with HIV a life expectancy comparable to HIV-negative people. Test and treat can facilitate accelerated scale-up of antiretroviral therapy in low-coverage countries, in conflict and emergency settings, and for hard-to-reach groups. In such settings, test and treat is feasible and should be considered as part of the standard package of care. It is vital that test and treat be provided to everyone, everywhere, and not only specific populations or hardest hit regions. Although implementation is challenging in certain contexts, it is no excuse for inaction. MSF also welcomes the first global health sector strategy on viral hepatitis, reducing inequalities in affordable access to quality-assured diagnostics and treatment will be pivotal in eliminating viral hepatitis as a major public health threat by 2030. The elimination of viral hepatitis by 2030 will only happen if fundamental political decisions are taken and implemented. They are ambitious hepatitis immunization programs, proactive action against high prices for life-saving drugs, issue in both low-middle income and in high-income countries, reduction of the unacceptable regulatory lag time for the registration of new drugs in low and middle-income countries, and refusal of any unethical anti-diversion policies of pharmaceutical companies, and universal access to affordable, quality-assured diagnostics and generic medicines. MSF urges member states to endorse the global health sector strategy on viral hepatitis and to provide resources for its timely, large-scale implementation. Thank you, Chair.
Thank you, MSF. Now I give the floor to Medicines Patent Pool Foundation, to be followed by Medicus Mundi International.
Thank you, Chair. The Medicines Patent Pool, or MPP, welcomes the draft WHO strategies for HIV and viral hepatitis. The strategies offer a roadmap for addressing two major health challenges and highlight the need to ensure the supply of quality and affordable medicines. Voluntary licensing is identified as a way to enable competition among manufacturers and reduce prices. Negotiating voluntary licenses is the focus of the MPP, the world's first public health-oriented licensing mechanism for medicines. Mr. Chair, the MPP was created and is fully funded by UNITAID, following a recommendation from the WHO Global Strategy and Plan of Action on Public Health, Innovation and Intellectual Property. It works in collaboration with member states, community groups, industry and civil society to facilitate access and promote innovation for pediatric formulations and fixed-dose combinations. This is achieved through non-exclusive, public health-oriented licenses with patent holders that incorporate key access provisions. The Medicines Patent Pool has partnered with 7 originator and 12 generic companies. This has enabled more affordable access to WHO-recommended treatments in over 100 countries. The new first-line medicine dolutegravir, for example, which was recently added to the WHO guidelines, licensed through the MPP to 9 generic manufacturers who will be able to supply generic versions in approximately 130 countries where 94% of people living with HIV in developing countries live. The license was recently expanded to include all lower middle income countries, including, for example, Ukraine and Morocco. Following the recent mandate expansion of the MPP into hepatitis C, the Medicines Patent Pool already negotiated its first license for daclatasvir, a treatment that is already a part of the WHO's essential medicines list. The license allows quality-assured manufacturers to make generic versions for supply in at least 112 countries. We welcome our close collaboration with the WHO in HIV and now in viral hepatitis, and look forward to working with member states to further increase access to affordable treatments in developing countries. Thank you.
Thank you, MPP. Now give the floor to Medicus Mundi International, to be followed by World Hepatitis Alliance.
Thank you, Chair, for this opportunity to address distinguished on behalf of Mycetoma Mundis International and People Health Movement. We welcome the 3 draft global health sector strategies. However, they are deficient in explaining how the strategies would effectively overcome some key barriers. There is a need to fast-track upscaling of the response to AIDS that need new money, largely realized from domestic resources. The strategy is silent on the ability of low middle-income countries to raise such resources under the chokehold of the current global economic structures. The hepatitis strategy does not address the barriers related to the very high monopoly cost of diagnostics and drugs related to hepatitis virus and hepatitis C virus, nor addressed are barriers to provision of clean drinking water and adequate sanitation in low-resource and emergency settings. There exists today a real opportunity to eradicate hepatitis C, but the promise of recently launched drugs such as sofosbuvir is nullified by the extremely high market prices of these drugs and the lack of strategies to promote low-cost generics in all parts of the world afflicted with high level of hepatitis C incidence. We urge the WHO to provide technical support to member states to decisively use TRIPS flexibilities to promote introduction of low-cost generic versions of the newly introduced anti-hepatitis C drugs. It is beyond belief that a single pill of sofosbuvir was marketed at a price of $1,000 a pill, when evidence suggested that a 3-month course of the same drug should cost around $100. Low-income countries struggle today to keep alive even the existing immunization schedules. In such context, the sexually transmitted infection strategy needs to fully consider the opportunity cost of adding human papillomavirus vaccine to the routine immunization schedule. Thank you.
Medicus Mundi International. Now I give the floor to World Hepatitis Alliance.
Thank you, Chair, for the opportunity to address the Assembly. Honourable Ministers, distinguished delegates, on behalf of the 400 million people estimated to be currently living with viral hepatitis, the World Hepatitis Alliance welcomes the first global health sector strategy to address the issue. For us, this is the single most important document on viral hepatitis ever produced. For many years, our community has felt consistently under-prioritised and indeed very much left behind. And we felt it again when Sustainable Development Goal 3 committed the world to end the epidemics of HIV, AIDS, TB and malaria, but only to combat viral hepatitis. So we applaud the Secretariat for developing a strategy which moves beyond combat to an unambiguous goal of eliminating hepatitis B and C as a major public health concern by 2030, and for including clear targets to drive the action we so desperately need, but in such a way that it strengthens health systems, not depletes them. And this is could save over 7 million of us from dying of cirrhosis or liver cancer. The elimination of viral hepatitis by 2030 is ambitious, but it is feasible, provided there is clear message of political will from member states. Please endorse the Global Health Sector Strategy on viral hepatitis and, critically, the goal of elimination. Thank you.
Thank you, World Hepatitis Alliance. Now I give the floor to India.
Thank you, Chair, for this opportunity. Our comments are for all the three strategies for HIV, hepatitis, and STIs. The WHO draft Global Health Sector Strategy on HIV comes at an important time when the world has committed to end the AIDS epidemic by 2030 as part of the Sustainable Development Goals. The sectoral strategy on HIV will be critical in achieving many of the SDGs. India notes that the strategy is aligned with the Global HIV Strategy adopted by member states in the UN AIDS Program Coordination Board in October 2015. Interventions in the health sector, strengthening of health systems, and the role of WHO are important if the world has to achieve the targets set for HIV/AIDS. It's also critical that the global strategy emphasizes linkages with co-infections such as TB and hepatitis. In fact, in coming years, HIV services should also develop linkages with non-communicable diseases, including mental health. Adequate emphasis on ensuring access to affordable HIV medicines, including second-line drugs, is also required. India is committed to ending the AIDS epidemic. We have come a long way in the last 15 years. New HIV infections have been reduced by more than 66% since 2000. AIDS-related deaths have declined by more than 54% since 2007, as we have scaled up access to antiretroviral treatment. We have also introduced CB-NAT tests for rifampicin-resistant TB in many ARV centers, and this coverage is being expanded rapidly. Diagnosis and treatment for both HIV and TB is cost under our national programs. India's contribution to ensuring access to quality generic medicines for HIV is well acknowledged globally. We will continue to contribute to international community's efforts in ending AIDS epidemic by 2030. The draft Global Health Strategy for Viral Hepatitis identifies the relevant interventions in a fairly comprehensive manner with the focus on hepatitis B and hepatitis C, where the risk factors and modes of transmission are the same. In the strategic vision, however, the aspect of prevention, though implicit in halting the transmission, should be specifically mentioned. This will ensure that preventive aspects, which are so vital and cost-effective, get the desired focus and prominence. We also suggest that the strategy should have a specific priority for developing hepatitis C vaccine. Insofar as hepatitis B is concerned, vaccination against this infection has already been included in our universal immunization program. We have also noted the proposed strategy for sexually transmitted infections. We would request WHO to share with us more scientific evidence on HPV vaccination for elimination of cervical cancer and genital warts. It would be important to assess the evidence regarding immunity provided by HPV vaccine, events, target age groups, requirement of repeat vaccinations, and whether other cost-effective and equally efficacious interventions are possible from a public health point of view. The draft strategy has given ambitious milestones for 2020 with estimation of resources required for full achievement of these goals. We presume that these estimates have emerged after due diligence. However, making these funds available in the face of competing demands for health-related SDGs is going to be a major challenge. Thank you, Chair, for this opportunity.
Thank you, India. I have no more speakers on my list. I shall now ask the Secretariat to respond. I give the floor to Dr. Ren Mingkui.
Mr. Chair, distinguished delegates, thank you very much for your constructive interventions on the global health sector strategy on HIV and viral hepatitis. The strategy I initiated and developed at a time when we are working towards the great integration for the universal health coverage. The strategy, while maintaining the clear disease focus, also provides a roadmap towards great integration of disease-specific intervention and services into broad international health programs health systems. We must recognize that HIV and viral hepatitis continue to represent major public health threat. We also need to be reminded of SDG, where disease-specific target and actions are required if we are to achieve target on ending the epidemic of HIV, combating viral hepatitis. Global strategies on disease are still needed to focus investment on higher impact disease-specific intervention and services with the integrations of health systems. We are very pleased to hear your positive comments and your willingness to endorse the strategy and draft the resolution. We fully understand your concern that the strategy might cause. As the strategy resolution states clearly, Member States should implement proposal actions as outlines in Global Health Sector Strategy, adapted to the national priorities, legislations, and specific contexts. It is true that the strategy introduces ambitious targets and call for increased overall investment in health. There are major opportunities to reduce the cost of diagnostic, medicines, and services, including through the use of comprehensive price reductions strategy and promoting personalized services. We note your concern of a high price of hepatitis C treatment. It is a challenge in a resource-limited context. Meanwhile, in higher-income countries, price computation is increasing as new treatments become available. In lower and some middle-income countries, the introduction of generic medicines has led to treatment cost much lower than ever a year ago. A cost of treatment that was once priced over $80,000 US dollars now can be funded in some countries for less than $900 US dollars. I dropped to below $300 US dollars in number of lower and middle income countries in the foreseeable future. This assembly will pass several resolutions to help expand access and affordability of medicine, providing new platforms and channels to address the higher crisis of hepatitis C medicine. You also mentioned the linkage of this strategy with the Global Action Plan on Antimicrobial Resistance, which is adopted by the Assembly last year. Prevention and management of antimicrobial resistance is critical to the HIV and hepatitis strategy. We are in the process of developing an action plan to address HIV drug resistance, which is referred to and is close linked to the AMR strategy. Clearly, more can be done to ensure that issues related to the HIV hepatitis are adequately reflected in the AMR program of work. As many delegates pointed out, one size doesn't fit all. WHO secretaries working closely with Global Fund to fight HIV, TB, malaria, and other partners will address your specific concerns as we take the three strategies forward to ensure that are promoted and implemented widely in the countries. In conclusion, I would like to thank you once again for your support and thank the colleagues of my teams and the UNAIDS for their wonderful job. I thank you, Mr. Chair.
Thank you, Dr. Ren Mingkui. Now, the floor to Dr. Busterio.
Thank you very much, Mr. Chair. And let me add a few words in relation to the comments that have been made on the strategy for sexually transmitted infection. First, we are equally pleased, excited, as my colleague has expressed, that these strategies are integrated and they are really based on the concept of universal health coverage. That's exactly the new way that we from WHO Secretariat, together with you, will be working in the era of the Sustainable Development Goals. I think this concept of the integration of the activities that are addressing sexually transmitted infection has already achieved some successes, Mr. Chair and distinguished delegates. For example, on the elimination of mother-to-child transmission of HIV together with syphilis. And not only the concept has achieved success, but also we have had some countries, like the delegates from Brazil so proudly recalled, like Cuba, that has achieved that elimination. So clearly that's a way to go. I think I'd like to add also that the integration of these strategies with the adolescent health program is particularly important. And just yesterday, this distinguished gathering also approved a very important strategy on women, children, and adolescent health. And looking at adolescent as very, very important population for the future of our health in the planet, and including prevention activities, and particularly, as was discussed by many here, vaccination with human papilloma virus. I would like to say, particularly to the delegate of India, many others that have raised this issue of HPV, we are available to provide the evidence that is needed for you to make the policy decisions. We now have, the world has advanced tremendously because more than 30 countries have introduced HPV vaccination in adolescent girls with the support of the Global Alliance for Vaccine and Immunization. And we are learning a lot on what is the best service delivery model that is needed. And clearly, there is a lot that we can share with countries so that this scaled up, and also, as many of you have mentioned, the cost of the HPV vaccine can continue to move down, because this, we are aware, is a critical limitation. Mr. Chair, my colleague has already mentioned the important link of this discussion with the antimicrobial resistance, and particularly for gonorrhea. I'd like to say we are facing a world where we have a critical gap there, and I'd like to inform the distinguished delegate that they have called for additional diagnostic tool and additional recommendation on surveillance, that we are working on those, and they will be published in July. So stay tuned, there will be additional information and additional way forward. My final point, distinguished delegates and chairperson, is many member states and the NGOs that have spoken have discussed about the importance of financing and sustainable financing for this strategy. It's clearly important to note that the financing of this strategy has to be first and foremost domestic, but it can and it must be supplemented, particularly for the first years, by the financing that is coming through the Global Fund, through UNITAID, through PEPFAR, through the Gavi, and also other ways of financing. From the Secretariat, from our teams, we are really looking at how we can work together with these financing instruments in a more synergistic and more effective way to provide that financing that is still so clearly needed. Have a good afternoon.
Thank you, Dr. Bustorio. Is the committee to approve the draft resolution? Since there is no amendment being proposed to this resolution, I therefore take it that the committee is prepared to approve the draft resolution contained in document A69/59. I see no objection, so the resolution is approved. That concludes our discussion of agenda item 15. Ladies and gentlemen, before we going to lunch, we shall now review our third report. You may refer to document draft A69/74, which was distributed this morning. Please note that the date of the fourth and fifth meetings should be correct to read 27th of May 2016. I would like to give the floor to our rapporteur, who will read out the draft report. Mr. Sidikov, you have the floor.
Chairman, thank you. Third report of Committee B, draft. Committee B held its fourth and fifth meetings on the 27th of 2016, under the chairmanship of Dr. Mahlet Kifle, Ethiopia, and Dr. Fusit Prakongsai, Thailand. It was decided to recommend to the 69th World Health Assembly the adoption of the attached two resolutions relating to the following agenda items. Health System 16.1 Health, Workforce and Services, one resolution entitled Global Strategy on Human Resources for Health, Workforce 2030. 16.4 Addressing the shortages of medicines and the safety and accessibility of children's medication, one resolution is amended entitled Promoting Innovation and Access to Quality, Safe, Efficacious and Affordable Medicines for Children. Thank you.
Thank you, Mr. Slikov. Are there any comments or observations? I see none. May I then take it that the committee adopts its third report? I see no objection. It is so decided. The report will be submitted to the next meeting of the plenary. We will start the seventh meeting of the committee be at 2 o'clock sharp in the afternoon. So the meeting adjourned, and enjoy your lunch.